Hello, Dr. Himanshu. Hello, Dr. Anil.
Hello.
Dr. Vinay is also joined. Hi, Himanshu. Hope you are hearing us from the viewers box, right?
Hi, everybody.
Hi, Anil. Hi, Vinay. We'll wait for Dr. Geeta too.
Yeah.
Yeah, I think you've given her time as 6:05.
I'll ask her to join early.
Okay.
Sujit, I hope we are not live.
We are live.
Is it? Okay.
Yes, we are live. We have to behave ourselves. Yes.
Do you want me to test my share screen?
Sujit, I hope we are not live.
We are live. You can get ready with that.
Okay.
Yes, we are live. We have to be here. There won't be much delay for starting our presentations.
Okay, no problem.
You can get ready. Yeah. Welcome, Dr. Geeta.
Hi, Geeta.
Yes.
Do you want me to test my share screen?
Sujit, I hope we are not live.
We are live. You can get ready with that.
Okay.
Yes, we are live. We have to be here. There won't be much delay for starting our presentations.
Okay, no problem.
You can get ready. Yeah. Welcome, Dr. Geeta.
Hi, Geeta.
Dr. Himanshu, I'll share my initiative.
Sujit, I hope we are not live.
So if something happens to my control, get ready with that.
Okay.
Yes, we are live. We have to be here. There won't be much delay for starting our presentations.
Okay, no
So
problem.
we'll start our academic program. We are ready with our panelists. Dr. Himanshu will take over from me and take the discussion forward. We have Dr. Anil and Vinay in the panel as moderators. They will be taking the questions from the chat box. All the viewers are requested to put your questions in the chat box. And Dr. Vinay and Anil will bring the... Dr. Geeta is left. Will take the questions for a discussion with the panel. And we have actually Dr. Emesko also sitting in the viewers box. Welcome, Dr. Emesko. We are unable to see you, but I've seen your name in the viewers box. So we welcome you. You will be in the panel in part 2 of this program. So welcome all viewers, and let's start the academic program. Dr. Himanshu can take over.
Okay. Very good evening to one and all, and I'm so thankful to Kozhikode Ophthalmic Society, and special thanks to Sujit for inviting us and making such a wonderful program, and having our eminent guest speaker like Dr. Carol Karp and having Dr. Geeta, and that's something which is really wonderful. So I would request Dr. Sujit to introduce the first speaker, and we can start the program.
Dr. Himanshu, that actually the official introduction has been done.
Okay, great.
So it was done probably, I think you joined late. So it is done. So I think you can call her for the talk directly.
Okay, Sujit, my program list, would you be able to get the list on? The topic list? If you can start with the first, Sujit, then I can fish out the topic list.
There's no issues. No issues.
Copy. Can you help me with something, please?
You have to go to the next box, Dr. Carol.
Okay, let's just see here.
In which your open PowerPoint will be seen.
Okay, let's try this. Okay, can you see that now?
Yes, we can see you. You can start.
Okay, perfect. Let me put it on screensaver. Okay,
Yes.
great.
You're all set. Yeah.
Okay, perfect. Great. Well, good evening, everyone, and thank you so much for the kind invitation to be with you all today. And I think, as was said by Dr. Meena, that there is a silver lining to all these difficult times that we're having, that we are now utilizing more and more Zoom meetings, and that we can all be with each other while not physically, at least connect intellectually and personally our electronic devices. And I thank you so much for the very kind invitation. It is really my honor to be here with you this morning for me, to share with you a discussion of my favorite topics, which is the management of ocular surface squamous lesions. And today I'll be talking about squamous neoplasia. And I do see many tumors every day. I promise my visitors at least 10 tumors a day. And if anyone is able to visit when Miami is clear of this being the epicenter of COVID, you are most welcome to come and share in my enthusiasm. So I have no financial interests to disclose, but I will be discussing off-label use of approved medications. And I have a wonderful team of researchers and fellows that help me with what I do, and just wonderful colleagues. And I thank you all so much for having me here today. So we're going to start with a case of a patient. He was 95 years old, and this is what his eye looked like. And we'll say, well, what can we say about this particular lesion? So one, I would say, okay, it is in the exposure zone. There's some feeder vessels, and it really has a very gelatinous appearance, mostly over the cornea in this case, but emanating from the limbus. So what is this? Is this a pannus? Is this a degeneration? Well, this is a classic appearance of ocular surface squamous neoplasia. Then the question is, so what are we going to do with that? Yeah. So the first traditional management of this would be to do surgery. And if we're doing surgery, that means I have to take out the tumor, but I also have to take a margin of clear tissue that I'm going to be removing 360 degrees of every limbal stem cell, ending up with stem cell deficiency, and then calling on my dear colleague and friend, Dr. Guillermo Amezcua, to help rehabilitate the ocular surface. So I have some medical options, and that is for interferon, which in India you know very much about, and I have used a lot here in the US, which we'll talk about, 5-fluorouracil, and mitomycin. There's some other drugs, but these are the main 4 options that we have to manage this tumor. So let's just take a step back and talk a little bit about what is OSSN, or ocular surface squamous neoplasia. And this is the umbrella term that we use to describe mild dysplasia of the cornea or the conjunctiva, to intraepithelial neoplasia, to invasive squamous cell carcinoma. And it has different appearances. Sometimes it can have this an obvious mass. Sometimes it can be a little more subtle, sometimes it's more opalescent on the cornea. And the main risk factors, number 1, 2, and 3 are sun, UV, but also human papillomavirus and immunosuppression play an important role in the development of this lesion. What we're going to talk about with the next lecture, but I do want to mention now because it helps with every patient that I see, what is the new and exciting, in addition to topical medication and chemotherapy, is the use of high-resolution OCT that lets me see what is going on within these masses on the ocular surface. I use it to help me diagnose what's going on, but also to help me follow the patient with medical therapy to make sure it's gone and to check for any early recurrences. And in addition, in settings of complex ocular surface disease that we're going to be talking about later today, it's also very helpful to identify areas of neoplasia that clinically may be difficult to see in an eye that has other confounding factors. So let's look at an OCT, and this is the OCT of that 95-year-old that I just described. And when I look at an OCT, which we'll talk about more in the next lecture, I first look for the normal epithelium, which here you see is dark and thin on the right part of the screen over the cornea here. And then you see a very thickened hyperreflective epithelium that's marked with the asterisk. And here you see some shadowing, but you can see that there's a nice border and demarcation between the tumor and the underlying tissue. Sometimes you can't see that, but in this case, we can see that it's right on top of the cornea. So there you see the normal, the thickened hyperreflective epithelium. And this abrupt transition is what you see in histopathology and is mirrored by the morphology that you see on the OCT. And these are classic findings for OSSN. So next we're going to talk about more our treatment options. As we said, surgery. The great thing about surgery is that it's over fast, unless there's, of course, recurrences. It's covered by insurance here in the States. The problem is it's hard to ensure that you've gotten every little morsel of the medication off, every morsel of the tumor off. You do your best guess as a surgeon to try to hopefully clear any visible tumor, but you can't guarantee that you're going to get every little seed. And as I mentioned, extensive excisions, like in this 95-year-old who has tumor all over his eye, end up causing stem cell deficiency, scarring, diplopia. So the medications that we briefly mentioned, they have the great advantage of treating the entire ocular surface. So when the patient takes the drop, it goes all over. So you don't have to be a magician knowing where it is and where it isn't, because the medication goes all over and it helps them treat the subclinical disease, microscopic disease. And the options we are going to talk about, we already said. The downside is that it does take time and it does take compliance and out-of-pocket costs in the state. I'm not sure in India if this is covered for the patients or not, but our patients do have to pay out of pocket for it. And some of the medications do have some side effects, mostly the 5-FU and mitomycin. So in this gentleman...
Dr. Kaur?
Yes.
Can I interrupt for a moment? I think there is some problem in the telecast. We are getting few messages that they are unable to connect. So can we wait for a moment, please? Yeah.
Of course. Just let me know.
Sujit, we are able to see here clearly. So
yeah, we are getting few messages from the viewers not getting. Just let me check for a second.
Yes, sure, absolutely.
Do you want me to stay sharing the screen or change?
You can stay sharing the screen.
Okay.
Yeah, Sujit, it's very visible here. It's perfectly clear here.
Yeah, I think so, but I don't know. One message I got from, I think Dr. Kaur's fellow, Eric, it's there. Dr. Shivan is saying.
Okay.
It looks like it's on their side. I think rest everybody can see clearly.
Okay. Yeah, then we can continue, Dr. Kapp.
You can proceed.
Yeah.
Okay. All right. Very good. Well, hopefully everybody can see. So our patient comes in, and the first thing he says to me is that my doctor said that I have a cancer and that it's big. That is true. And then he said I need surgery immediately. And I'm 95 years old and I don't want surgery. So that's my dilemma basically every day is do I do surgery on this patient or do I treat them medically? And then we're going to talk a little bit about the pros and cons and how I decide about what is going to be best for my patient. So when I'm faced with a primary or a recurrent lesion, if it's small, I think that either surgery or topical medication are going to work very well, and it depends on patient compliance issues and also the classic findings clinically to diagnose the OSSN or by high resolution OCT. Now, when a lesion is very large or annular meaning it goes all around the limbus, as in our patient here that's 95 years old, we know that surgery is going to cause stem cell deficiency. And in addition, that it's going to be potentially difficult to ensure that we're going to get clear margins. So in that scenario, I have a very strong preference for medical therapy. And when I have recurrent lesions, meaning they've already had several pieces of their eye removed, or it's a deep lesion, then maybe surgical. And sometimes we need to combine therapies. So what do we do with this tumor? Both the patient and I preferred medical therapy for this 95-year-old gentleman. And let's first talk about what was my favorite medication. My favorite medication was topical interferon, which I like to call my angel drop because it was so well tolerated. I give it as 1 million international units per ml. That's the concentration. I give it 4 times a day, and it's an everyday drop. A minimum is really 4 months to completely have the tumor resolve. I have the luxury of the OCT, so I can be sure that the tumor is gone. What I tell others and what we've published on is that if you don't have the luxury of an OCT, once you see that it's clinically gone, you should treat for another 6 weeks with your topical interferon just to ensure that you've eradicated the microscopic disease. You can also give interferon as an injection, which I give as 3 million international units in half a cc. In my original publications, I gave this 3 times a week, which was what and how we treated hepatitis, which was 3 million 3 times a week. People got subcutaneous injections. And that's how I started doing it, just imitating that. But now I do it once a week because they do get flu-like syndrome, feel malaise, sort of COVID-like. So it's different than the drops, which have really no side effects at all. So that's why I call it the angel drop. And it has very high success. In India, you guys use lots of it. And in India, you have the benefit of it being a very inexpensive drop. I think Geeta, when she came to visit me, said that it costs $1 or $2 for interferon. But in the States, it's become very, very costly. It's cost we charge $800 per month for the topical interferon. So that is a big drawback. And it also takes a lot of time. I think that it's probably cheaper to go to India and to fly there and stay there and get treated with your interferon there for $1 or $2 than it is to pay the $800 per month. So let's look at some cases with interferon. Here's a patient that I like to show who has a leukoplakic and gelatinous lesion with classic thickened hyperreflective epithelium. And he took topical interferon for 4 months and had a beautiful resolution, which you can then see on OCT. clinically, he looks great, but you can see that the epithelium is totally normalized after treatment. Here's another patient that had very subtle tumor here, and this would definitely be harder to guess where the margins were when you were doing surgery, which is another great advantage of doing topical medication. So here's the patient, and then here's the patient after 5 months of topical interferon. So because of the costs in the States, my favorite has switched to topical 5-fluorouracil. And this is a drop that is cycled instead of being an everyday drop. And that gives the advantage also, it's easy for patients to do because they do one drop 4 times a day for 1 week, and then it's off for 3 weeks. It generally needs 4 cycles. So remember, 4 months of interferon and generally 4 months of 5-FU and not more than 4 cycles of mitomycin. So in the States, this is our bargain. In India, all the drugs really are a bargain, but in the States, the 5-FU is only about $35 per month, and it also enjoys very high success rate. The downside is that it does cause some discomfort, not as bad as mitomycin. So I call this the assistant devil drop, or in a lot of our patients speak Spanish, so I call it the diablito, which means the little devil. And of course, compliance is a problem with any drop. So looking at how this works, this is a patient that had a very papillary lesion here. I gave him 2 months of 5-FU, and this is the way his eye looked. Now, remember, I'm going to do 4 months in general. And while I have the OCT that can ensure eradication, I do say that if you are, again, if you don't have the OCT, after you see clinical resolution, I would then give another bottle or do another 2 cycles of the 5-FU just to ensure that every morsel of the tumor is gone. So looking at a tumor that is more extensive here, that's all around the limbus, another extensive tumor. Then here is the patient. In this case, I did 7 cycles. And remember, they're only 1 week cycles. Now, what's my least favorite? It's probably the drug that ophthalmologists are the most familiar with, which is topical mitomycin. And this I use 0.04%. I also cycle it 4 times a day for 1 week only. And then the most important thing with mitomycin topical treatment is that you wait until the ocular surface is healed. I think a mistake that people use, is that they use the mitomycin 1 week on, 1 week off, or when the ocular surface has disrupted epithelium, that's when really the tremendous toxicity occurs with mitomycin or 5-FU. So you need to wait until the eye is white before you can then repeat it. Success rates are very high. In the States, mitomycin is very costly, and I know in India it's also not very costly, but the bottles charge $300, $400 per bottle. You also do need punctal plugs, which is another expense for our patients, and it requires compliance and refrigeration. And it is the worst in terms of side effects for the ocular surface, causing stem cell deficiency, melting. Dr. Amesco and I just recently saw a patient yesterday with side effects from mitomycin from pterygium surgery. So it's really a devil, in my opinion. So here's an example of a patient that I did use mitomycin for, who had an extensive tumor all over his ocular surface, and mitomycin cleared it up the way I could not with surgery. And then here's a little bit left over that I'm going to need to continue to treat with. So let's go back to our 95-year-old gentleman. So I decided to treat with 5-FU. And remember, I chose 5-FU because in the States, that is the most economical. It's also easy for patients in terms of access to the drug because it's a drug that's given 4 times a day for 1 week, and then they're off, and then they take their next cycle. They can take the drug home, they get the medicine from us, and they can do 2 cycles and not have to order the medication or come back in between. So that's what I put him on. And here's what he looked like after just this. In this case, it was 6, even though usually it goes away with 4. This is a biggie. So I do it until it's gone. And here's his before, and here is his beautiful after picture. How about the OCT? So remember, my high resolution OCT helps me diagnose and also helps me follow it. So here you see, this is the area of the scan. This is the image we saw before with thickened hyperreflective epithelium. And then now after, in the same location, what you're going to see is completely normalized, thin epithelium in the conjunctiva and on the cornea. So this is gone. But of course, medical therapy does take time. So you need to be patient. And I like to say that good things come to those who wait. So when you're going to treat someone with medical therapy, they do have to be compliant and they do have to be patient. So they have to be a patient. Just let's switch and talk a little bit about surgical excision and how I do it. So Dr. Carol Shields has taught us, and we teach a course at the Academy every year on excision of conjunctival lesions, that we are best served by doing wide excision, which means about 4 millimeters if you're able. No touch means that obviously you have to touch the tissue, but you take the area outside where you think is clear margin and then dissect that, and only last do you actually touch where you think there are tumor cells. When I take off the lesion, I orient it on a piece of paper, and this is very important to be able to know that if a margin is positive, which one. So here you see I wrote superior, temporal, inferior, and then this needs to go over in pencil, because once you put it in the formalin, the ink dissolves, and then Dr. DeBovi is able to tell me if I cleared my margins. Absolute alcohol for 1 minute. This helps get rid of and debride epithelial cells that are left. And then I scrape, remove that, and I send these cells all for analysis. I do double freeze, slow thaw, to both the conjunctival margins and to the limbus. And this is my retina probe that I've just taken the sleeve off, and then I put it all as much as I can on for the deep freeze, slow thaw. And then I usually close with amniotic membrane and tissue glue. So what should we do and how do I decide? Well, if a tumor is very large, if it's multifocal, like our 95-year-old, surgery we know is going to cause stem cell deficiency. And I think that it's a good idea to start with medication. Most of the time, as I said, 85% of the time to 100% of the time, you're going to be able to cure the patient with your medicine. But even if not, then you chemo reduce it so that at least you'll be able to do a smaller surgery. Now, if this is a recurrence following multiple surgeries, I also prefer to do medication, but you know what it is, and the patient has already had many stem cells sacrificed or scarring. The real question that you need to explore with your patient is about compliance. If they're not going to take the medicine, then it's not going to work. I mean, you can do injections that ensures that it gets in there, but the patient still has to show up. So if you feel like this is a patient who is not going to show up, is not going to be able to take their drops, then definitely this is a patient who needs surgery. The other thing is that if you're not sure what it is, again, I have the luxury of the high resolution OCT and I can see classic features. But if there's something that's fishy, something that's unusual, something that I don't like about the OCT, if you have a doubt about what the diagnosis is, then surgery is necessary because it's both diagnostic and therapeutic. If the lesion is stuck or fixed onto the globe, that's also another reason when I prefer to do surgery so that I can do a sclerectomy and get the deep margin. Now, if I'm going to treat topically, what is my choice then? Well, then I do 5-FU or interferon. If money is not an issue, then interferon is my favorite. If cost is an issue, then 5-FU. And so how do I decide? How do I play? Unfortunately, we're not going to be in Las Vegas this year, but basically the factors that I think about are if they can afford, if they can get the interferon, if they're going to be able to keep it cold, and if they're going to be able to put it in. 5-FU has become my go-to drug. It's also, as I said, very helpful because it's becoming difficult to even get interferon. Only certain sites can have it. We make it. So 5-FU is easy. They take the drug with them, and then they can do their 2 cycles before they need to see me again. And also 5-FU seems to work better in patients who are immunosuppressed. So we've published on this because interferon is an immunomodulatory. It revs up the immune system to fight the cancer. We've noticed that in patients with atopy and other immunosuppressive diseases, 5-FU works better. And then my last resort for topical is for the mitomycin. Again, if you start with something and it works, great. And if you notice that then it stops working, there's a plateau, it's always good to confuse the tumor. So this is not common, but if I had a scenario where the tumor was resolving, but there was a little stubborn area that wouldn't go away, then I can either operate or I could just switch medications, and that will often take care of the tumor completely. So in summary then, excision with cryotherapy definitely works, but in extensive tumors, it can lead to stem cell deficiency and recurrences because we can't get every morsel of the tumor out. Mitomycin, 5-FU, and interferon are very helpful. Interferon has been my favorite because of the well-tolerated kindness to the ocular surface in the form of the drop. But now I use more 5-FU because in the States, interferon is very expensive and hard to get. And then sometimes we need to combine modalities. Thank you so much for your attention.
Thank you, Dr. Shah. And that was, as usual, wonderful lecture on management of OSSN. There are a few questions here. Dr. Shri Danya is asking, when you're talking about perilesional injections, how often do you give? And what will be your endpoint? And similarly, when you're treating topically with the drops, what would be your endpoint? And how does it matter if you do not have high resolution OCT? Does it change for anyone?
What was the last part you said?
If somebody doesn't have high resolution OCT, yes. Does it change the endpoint for the treatment? Yeah.
Okay, perfect. So the first question was injections of how often and how do I give them? So I use 3 million international units in half a cc. And that is the dose that is most commonly used for hepatitis. So it comes most of the time, I get a vial. That's an 18 million unit multi-dose vial. So patients who are on interferon for, say, systemic hepatitis, they will use it 3 times a week, 3 million, and they inject it subcutaneously. And so the vial, if you get an 18 million multi-dose, then I have 6 doses, and that usually can cure any tumor in 6 doses. Originally in my papers, I did it 3 times a week because I kind of made it up from what they do with hepatitis. But now I do it once a week. So I have clinic on Fridays. I inject them on Friday. What I do is I like to inject right, what I call perilesional, which means it goes into the tumor right next to normal conj, and then I balloon up the area of the tumor if it's that type of tumor. If it's on the cornea, I just inject at the limbus, not into the cornea. And if it's in the caruncle or another area, then it goes there. I prefer to do the normal conj right next to it because if you inject into the tumor, it gets to be like a bloody mess. So now I do it once a week. I do 3 million. If you ask this question to Carol Shields, she does 10 million international units per ml. I do 3, she does 10. So I'm little Carol, she's big Carol. I do it once a week and she does it once a month. So she gives 10 million once a month. I give 3 million every week. I think it's really dose related. The 10 million definitely will have some side effects, but it also depends on your ability to have your patient come back. The next question was about how do you know what the endpoint is? And this is for both drops and or the injections. And so I think for me, I do have the luxury of the high-res OCT. I can see that it's totally gone. But most of the world is not yet able and available to have this. So what we do is basically look for clinical resolution. So you're going to look for signs of staining with rose bengal or lissamine or toluidine. You're going to look to see that the tumor is gone. There's no leukoplakia or opalescence there. Clinically, that you don't see the tumor and the conjunctiva looks normal. But what we found, and we published recently in Eye and Vision, was that when it looks like it's gone, there could be some subclinical disease still there. We found subclinical tumor in 18%, or in, let's say, a fifth of patients had a little bit of abnormal cells, even when I thought clinically that the tumor was gone. So what we recommend is that if you're using interferon, you treat it for another 6 weeks. So you say, I'm happy to say it looks like your tumor is gone, but just to be on the safe side, to make sure that we get rid of every morsel of a seed that might be there, let's do it for another 6 weeks. And if it's 5-FU, I'll say, I'd like to do one more bottle here. They're going to do 2 cycles, 1 week on, 3 weeks off, 1 week on, 3 weeks off, just to be on the safe side. When we did that in our study that we published, if I did the additional, then even clinically, of course, I thought it was gone the first time, but when I saw them again, I thought clinically it was gone. But then by OCT, it was really gone. And in that group, recurrence rate was 0. So to answer the question, I would say treat them for 6 weeks more with interferon when you think that it's gone and you see no remnants of tumor, or if you're using 5-FU for 2 more weeks of the treatment.
Thank you very much. And one more question about the stability of interferon drops when you are refrigerating them or keeping outside. What would you suggest your patient? Do they always have to refrigerate? And how long do you allow them to keep? What is the stability of a drop outside when you give it to the patient?
So we do ask our patients to refrigerate the interferon all the time. And we also have them refrigerate the mitomycin. For the 5-FU, when I started using the 5-FU, I published saying a great advantage is it doesn't need refrigeration. So I would say for years, I never had my patients refrigerate the 5-FU, ever. But all of a sudden, I remember, I'm going to say 2 or 3 years ago, our pharmacist said to me, I think we should we're labeling it that they should refrigerate their 5-FU. I said, we haven't been refrigerating it. My patients have used it for years without it. He said, no, need to be refrigerated. It'll work better. So I don't know. We now have them refrigerated. So that works fine, but it worked fine when it wasn't refrigerated. I mean, like South Florida, like India, can get really hot. So I definitely don't want it on their dashboard in the car. But we have them refrigerated. In terms of the question of the stability and for how long, well, our pharmacy labels it for 15 days. I tell them for off-label. I've used it for 30 days. That's how it was initially labeled by our pharmacy. And we've used it that way in the past for a long time, and it works just perfectly that way.
You're talking about 5-FU, right?
And interferon. When I started using interferon, we labeled it for 30 days. So I'm not a pharmacist, and the pharmacy needs to do what they feel comfortable with in terms of labeling it, because they're ultimately responsible. But for years, we've used it for 30 days before they changed the labeling, and that worked just fine. So that's my opinion as a doctor, but the pharmacy is going to have their opinions for stability of the drug. But I've used it for years with 30 days.
Sure. Thank you. So nice. Thank you.
Yeah. Himanshu, can I ask a question?
Yes.
Please go ahead. Please.
Yeah. Once we have started these patients on topical medications, how will we assess them? Or when will we say that it is not responding or resistant to treatment?
Okay, that's a great question. So how long does it take to see response? And that's an important question I didn't cover. Thank you. You should see a response within 6 to 8 weeks. So I think when you start using it, have them come back in a month. This isn't something like, oh, it's like steroid, they're going to be better in 3 days. No. So have them come back in a month, in 6 weeks, to assess that you see something going on. You should see something happening between 1 month and 8 weeks. Something starts. And then you have to keep going. Interferon is slow and gentle. 5-FU is a little faster. Mito is faster. But you will see something. And then you just have to keep going. If at 2 months you see nothing, then it depends. I might switch. I might try a little longer. But the vast majority have some signs of success at the 2-month mark.
One question I have related to the current scenario. Now, if somebody is on treatment on interferon and unfortunately ends up having COVID, is there any change you suggest, or they can safely continue and there's no issue at all?
Meaning, is there any problem using interferon if they have a viral infection?
Yes.
Well, I have to say I don't know the answer to that. I can say that interferon has both antiviral and anti-neoplastic properties. So it does work against human papillomavirus, and it's been treated for other viral entities. So I would not think that being on interferon would be anything that would be problematic, because it does boost the immune system to fight viruses. So I'm not an expert, so I really don't know. But that would be my theoretical answer to your interesting question.
Dr. Kaur, I had a patient who had very severe flu-like symptoms after using interferon. It was subconjunctival was also used. So in such cases, what is your protocol like? And he actually refused taking treatment after 3 cycles. So injections of interferon give flu-like syndrome, malaise, fever, chills. That means you got it in. That means it's working for the injections. The drops really are generally very benign and have no symptoms. So I warn them all in advance, and I tell them, you're going to get the flu. Like this is a bad time right now to do that, for people to get flu-like syndromes. They're going to think they have COVID. But at other times of life, you tell them they're going to get flu-like syndrome. It's going to they need to take acetaminophen or Tylenol or ibuprofen every 4 to 6 hours after the injection. And that helps. And each time they get the injection, it's less of the response, but that's totally normal. That is a definite side effect of the injections. That generally does not happen at all with the drops. And if it's a little old lady that's not going to tolerate that kind of fever and from the interferon injections, that's not a good patient for an injection. And they'll do better with eye drops, where they just have no systemic side effects. But that is totally common, totally normal, expected. Thank you.
Good.
I think we can go ahead with the next topic. Dr. Kaur is going to continue with her next topic, which is ABC of OCT for ocular surface lesions. Over to you, Dr. Kaur.
Okay, great. I will share screen now. Okay. Let's see. Let me see if you're sharing. I'm sharing my screen here. Okay. Can you see my screen? Are you able?
Yes, we can.
Yes, we can.
Yes,
Okay.
we can.
Okay, perfect. So my first love was figuring out how we could treat these tumors topically without having to hack up the eye surface. And then I became interested in the new technology, which allows me to see what's going on. And really, for the most part, it really makes me look smart because I can see what is there and give a diagnosis. So let's see here if I can get this to them. So I have no financial interests to disclose, but I will be discussing, again, off-label use. And thank you all again for having me. So we'll do another case. This is a gentleman who came in with this lesion on the eye surface. And what you'll see is he said he had a pterygium for a long time, which that could be. But he thought it changed. And you see here, this is rose Bengal staining. That there is some rose Bengal staining now on top of this quote unquote pterygium. So the question is this iridium? Is there neoplastic? Is it both? What's going on? And so I like to joke with my fellows that I use my women's intuition to figure out if a tumor is a problem, if a lesion is a problem, or if it's not a problem. So I need to know whether I'm going to be relaxed or worried. And I can use my women's intuition, but what works really well is the high resolution OCT as my intuition meter. So I could biopsy, and in a biopsy for OSSN, what you see is an abrupt transition with thickened epithelium and disorganized epithelium that has dyskeratosis, parakeratosis, and as I said, the abrupt transition. And when it's invasive, it goes through the basement membrane. So we mentioned this in my last lecture. The first device that I used was a custom device. One of my colleagues, Dr. Jay Wang, who is a biomedical engineer, devised this for the ocular surface to look at the tear lake and dry eye features. And that device had 2 to 3 microns of resolution, and that's what I started with. And now I use a commercially available device of the OptiView, which I don't have any financial interest in. And that is the images that you're going to see today. And this has actually a resolution of 5 to 7 microns. Most ophthalmologists have an OCT in their office, but just not the adapter that lets them look at the surface of the eye. So I think that's something that everyone should think about and get used to looking at the ocular surface with their OCT. So what do we see? So the Vizanti, for example, this is a time domain device. It has 18 microns of resolution. It really is not good at looking at any details of the epithelium. It's very good at looking depth and looking at IOLs, positioning, etc. But when you look at the spectral domain device, this was our research device, you can really see details. You see the tear film first, and then you see the epithelium, and then you see the stroma, and you can see details of the endothelium too, which my colleague, Dr. Mohammed Al-Boushusha, has published on. So we've looked at this already, but we're going to review it again. What does an OSSN look like on OCT? So here's a lesion that could be a little bit subtle. I mean, you see some little hairpin vessels here, and you get a sense this is kind of gelatinous there. So let's look at the OCT. There's the image. And what you see here, again, you first look for normal epithelium, which is dark and thin. Then we see this lesion, which we see as epithelial. So in my mind, I have to decide, is my lesion epithelial or subepithelial? And in this case, this is an epithelial lesion, and there is an abrupt transition from normal to abnormal. Now, here you see the thickness. This measures it for me, is 193 microns. So just remember that for a moment, because our studies have shown that really anything over 120 microns with our OptiView device is very highly sensitive and specific for an OSSN. So even the morphology, which I told you, if you forget, what did she say? Thickened hyperreflective epithelium, abrupt transition. If you forget all that, remember, if your epithelial lesion is, depending on our device, 120, 140, over that, it's extremely likely that it's OSSN. So normal epithelium, I find the base, I decide if my tumor is epithelial or subepithelial. In this case, it's an epithelial lesion of thickened hyperreflective epithelium. This is OSSN with that abrupt transition. So this is what I was mentioning to you about just the thickness. So we looked at this with my custom device and found that if it was over 140 microns, it was very high sensitivity and specificity. And when I used my commercially available device, this was the ArtiView by Optiview, over 120 microns of epithelial thickness had 100% sensitivity and specificity for OSSN. So we're going to go over again step by step so that when you finish this lecture, you're going to know what to do to diagnose. First, you're going to look for normal epithelium. And remember, that's thin and dark. For the refractive surgeons out there, 50 to 70 microns. So that's what you're going to see first. So step A, find normal epithelium. Next step, find the inferior edge of the epithelium. So here I have that dotted for you. And then you're going to look and see, is the lesion epithelial or subepithelial? And in this case, this is an epithelial lesion. And we see it's hyperreflective, thickened, abrupt transition. And you see that the thickening is 511. So we've decided this is an epithelial lesion. It's thickened and hyperreflective. That's what the lesion is, in this case, an epithelial. And that there's also this abrupt transition. So that has all the features, including the thickness, that it's an OSSN, or ocular surface squamous neoplasia. But let's look at some other lesions in the time that we have. So this is a common problem. Yesterday I was showing my fellows a similar case of patients referred for this opalescent lesion on the cornea. So let's scan it and see, could this be a corneal CIN or OSSN? So here's my OCT, and this is by the Avanti. So again, first I'm going to look at my epithelium. So my epithelium here is 48, and actually right here, right in the mass of this opacity, my epithelium is 23 microns. And there's this thing underneath the epithelium, not part of the epithelium, under the epithelium. So this lesion is subepithelial. It's between Bowman's layer and the bottom of my epithelium. So this is not OSSN. This is some subepithelial lesion with hyperreflectivity. So this is actually what Salzmann's nodular degeneration looks like. This patient was bothered by it for contact lens use, so I removed it and confirmed Salzmann's nodular degeneration. Another patient, is this OSSN? A gelatinous lesion there temporally? So let's do an OCT. Okay, remember, we're going to find the normal epithelium first. That's 60 microns here. Fine. Follow the epithelium, and it's up here. Is this thick? It's 37. That is not thick. The tumor is below. This is a subepithelial lesion. So you can tell me right now, this is not OSSN. It's jelly-like and maybe referred for OSSN, but it's not. This is a hyperreflective mass, thin epithelium. And so we know this is not OSSN. This is what you see with melanoma. And so this lesion was not treated topically. This lesion was removed, and this was conjunctival melanoma. Sometimes we get a pigmented lesion referred for possible melanoma. And here you see this pigmented lesion. But the patient said they thought it had been there a long time, and we look at pictures of them, and they bring in their family albums. And the OCT here shows multiple cysts in subepithelial. There's my epithelium, and there's the cyst. So this is a subepithelial lesion with multiple cysts, and this is classic for a conjunctival nevus. Here's another lesion. We saw one of these yesterday. This is a salmon-colored lesion. This is in the superior bulbar area. And when I do the scans on this lesion, we see thin epithelium. Let's look over here. You see this 50 over here? This is normal looking epithelium, and you follow it. You could say to me, well, here it looks a little hyperreflective. I agree. But you can follow and see that it's thin. And I just want to mention that sometimes the epithelium is a little hyperreflective in pterygia in patients who have spent a lot of time in the sun, but it's thin when it's not OSSN. So here's thin epithelium. And then what you see is that the problem is below the epithelium. This big thing with dark monomorphic dots and this hyperreflective band, which I think is compressed tissue. So this is full of cells and it's pushing the normal conjunctiva. See here, the normal conjunctiva is kind of hyperreflective, pushing it. So this infiltrate is a dark, homogeneous infiltrate with little dot-like structures. And this is what you see with conjunctival lymphoma. How do I diagnose that? Well, I need to take a biopsy and send fresh tissue with gene rearrangement to diagnose whether this is a lymphoproliferative disease and if it is lymphoma or benign reactive. What's the treatment? Well, for conjunctival lymphoma, I always biopsy both eyes, regardless of whether I see anything in the other eye, and then the patient gets a systemic workup. So once I diagnose the lymphoma, is it in one eye or both eyes, and is it in the body? If it's isolated to just the eye, the standard gold treatment is external beam radiation. And so that is what this patient had. So there's my diagnosis of that homogeneous hyperreflective. And then after external beam radiation, you see that my salmon patch is gone. And what you see after treatment of my OCT in the same area is the epithelium is normal. And then you see the hyperreflective conjunctiva, but no more dark, black, infiltrative dots. This is a very common lesion that we see, and you see in India too. Long-standing lesion. And what this is you see here that there is normal epithelium. Here is some thin but slightly hyperreflective epithelium, and underneath is the stringy white stuff. So this is pterygium. And again, remember I mentioned sometimes over pterygium, the epithelium can be a little hyperreflective, but it's thin. And this is a pterygium. So here's our patient. Remember, we weren't sure what he had. Looked like he had a pterygium for a long time, but something seemed different. And what we see now, so you guys are all pros now, so you can tell me what this is, because you see here some epithelium that looks rather thin, and then you see this thickened hyperreflective epithelium, and then you see this whitish stringy stuff underneath. So what are we worried about this lesion? Well, yeah, because what we see here, again, we're going to see the thin epithelium, hyperreflective, but it's thin. There's the base of the epithelium. This is an epithelial lesion with thickened hyperreflective epithelium and abrupt transition. And then you're going to see there's a little bit of like pterygium-like material, subepithelial hyperreflectivity. So, oh no, this patient has a combination of OSSN and pterygium. So this particular individual had only one eye. He had lost his other eye due to an infection and endophthalmitis after cataract surgery. So he was not interested in having surgery on his only eye. So I decided to treat him with topical interferon, which I did, remember, for the 4 months of my usual. And let's see if it's really gone. It looks good. So here I see now when I scan, remember, here you're looking for the normal epithelium. This is the most normal epithelium. And then I see my epithelium very normal here, thin, and an underlying fibrous structure, which is my pterygium. So now I'm happy that I treated this eye and that the tumor is all gone. So let's review one more case. Here's a different lesion. It's focal. It's leukoplakic at the limbus. And this one may not be a big diagnostic dilemma, but I would say it's pretty avascular, but it's very leukoplakic. And so here is the tumor with hyperreflective, thickened epithelium, normal here, and abrupt transition. When it's leukoplakic, you do see more shadowing, although I can actually pretty well see the inferior border. So there's the border, there's my thickened epithelium and my abrupt transition. And then after 4 months of 5FU in this case, you can see how beautiful and normalized. What we said with the excellent questions during the question and answer session is, what do you do if you don't have an OCT? So you treated this patient. I did 4 months of 5FU. That means 1 week cycles. So 1 week every month. Patient comes back in 2 months, looks better. 4 months, looks gorgeous. So I have the luxury of the OCT and I can say, yay, it's all gone. If you don't have it, you could say, you know what, why don't we just be safe and let's just do a little bit more of the 5FU or the interferon just to be on the safe side. And then what I do is I watch them. So in their first year, they come back every 4 months. And in the second year, it's 6 months. And then after that, it's yearly. So here's the review. OSSN, ocular surface squamous neoplasia. By OCT, what we see is thickened hyperreflective epithelium. You find the normal, you find the base. If it's an epithelial lesion, it's thickened and hyperreflective. Remember the thickness, that's very suggestive, is going to be something over 120 or 140. This is 260, abrupt transition. This is a classic OSSN. Pterygium. Pterygium is a subepithelial lesion. The epithelium is going to be normal thickness. It can be hyperreflective due to sun damage. And the lesion is subepithelial and hyperreflective. Lymphoma, we see, is subepithelial with lots of little dark dots and a homogeneous. And often I'll see this band, sometimes yes, sometimes no, of compressed conjunctiva that's pushed up. And melanoma, I see a normal epithelium and then this subepithelial hyperreflective lesion suggestive of melanoma. And finally is nevus, where we see multiple cysts in the subepithelial area. So in summary then, high-resolution OCT is great technology for ocular surface imaging. There's a very high degree of morphologic correlation with histopathology, and I like to call it my optical biopsy because it provides excellent adjunct to clinical acumen and can help get me the answer. Thank you so much for your attention.
Thank you, Dr. Karp. That was really wonderful. I would say one of the most lucid presentation of making a subject which is so complex, so simple for all of us. Thank you very much. It was really wonderful.
Thank you so much.
Are there any questions for Dr. Karp? Yes, Anil, go ahead, please.
If you look at the other benign lesions like actinic keratosis or pseudoepitheliomatous hyperplasia, I think the OCT features would be sort of overlapping with OSSN. Is there a clear distinct difference between the benign lesions versus a lesion with your management would differ significantly?
I would say most of the time, the OCT can help you decide what it is. Uncommon lesions like PEH, pseudoepitheliomatous hyperplasia, you do not see an abrupt transition. So I think that the four things that you're going to look for are the thickening, the hyperreflectivity, and an abrupt transition. If you have some and not all, what I recommend, and the thickness, which we said over 120-ish. So when you do a scan on a lesion, it's first important to do it in multiple areas, because in one area it may be so thick that you get shadowing and can't even see. So sometimes it's best to do it in another area, and you need to have your technician scan in multiple areas. So sometimes then the image will be bad, and sometimes you will get one where you can see those features. And if you have a lesion that does not have all, say in PEH, is going to have thickened hyperreflective epithelium, but no abrupt transition, and you look up and down and you can't find it, then you can say, I'm not sure what this is by my optical biopsy. And then you're going to need to do a tissue biopsy to be able to get it. So there can be overlap with, I can't always get the diagnosis, but I would say the vast majority of the time, I can find the features that I need to be able to diagnose this correctly. And I've done many of these studies where I do the OCT and then I do the biopsy. So that's how I'm judging about whether it's right or wrong. But nothing is perfect. So if you see something and you have an OCT and there's some overlapping features, you just can't really figure out what it is, then that needs to be removed. Not something that's going to be treated medically because you're not sure what it is. That needs surgery.
Thank you. If there are no more questions,
I think there are two more questions for Dr. Kaur. Can you
sure,
finish
please
that?
go ahead. Yeah, I missed that if there is something.
Can you read it from the chat box? From Eric. I think she's from Bascom. She's asking, when searching for lymphoma, how far back can OCT scan go? Do you use a special technique?
Okay, thank you for that question too, because I did not talk about one limitation of the OCT is that it works best on the bulbar surface. I do have colleagues in Canada who are working on it for the skin and for the tarsal conjunctiva, but it does work best and you can see best with the bulbar lesion. So for lymphoma, I can image all the way down. Anywhere I can see with a slit lamp, I can get a nice image. So all of the bulbar surface, as far back as you can get the patient to look down, we can image nicely for lymphoma. If it's in the caruncle, difficult to get a nice clear image. On the tarsal conjunctiva, if there's a tumor there, also it's sometimes very difficult to really see what is clearly going on. So when I'm imaging a patient with lymphoma was the question, and if it goes way back, as long as I can get either a lid speculum or get the technician to hold the lid and the patient to look way down, anywhere on the bulbar surface, even if it's high or low, will image very nicely for lymphoma, but not if it's in the caruncular area. That's hard to see, or in the very lateral canthal tissue, it gets more difficult. So most of the time I can get nice images and get a diagnosis, but in certain areas, it's just not so clear. This is a good question. Thank you.
I think we can go to Dr. Geeta's talk. Dr. Geeta, please.
Thank you so much.
Thank you. Dr. Kaur.
Hello.
Yep.
Am I audible?
Yeah, you are audible. You can start sharing your screen.
Thank you. So can you see my
No.
presentation?
Yes.
Now?
Yes.
Thank you. At the outset, let me thank the organizers for having given me this opportunity to speak to you today. As always, it's a pleasure to listen to Professor Karp's wonderful talks. They were amazing. Thank you so much for teaching us so lucidly. And I will now go ahead with the topic that's been given to me, which is approach to chronic conjunctivitis. I think the number of conditions that fall under chronic conjunctivitis is very huge. And I have tried to do as much justice as I can to the topic with the help of case illustrations. I think I'll start by defining chronic conjunctivitis, which is generally accepted as conjunctivitis that has been present for greater than 3 weeks. And when a patient presents to you with a picture that is suggestive of chronic conjunctivitis that's been there for around that period of time, and you've ruled out the other causes such as scleritis and uveitis, you know that what you're dealing with is a chronic conjunctivitis. The further scope of the talk is basically revolved around chronic conjunctivitis, and I would focus on an algorithmic approach to these cases with a very brief overview of the disease and management plan with the help of case illustrations. I think the most pertinent questions that I would like to ask myself when I see a patient of chronic conjunctivitis is the laterality. Is this unilateral or is this bilateral? Is there a specific predilection for any particular lid in terms of affecting the upper or the lower lid, or is it just generalized? With respect to symptoms, probably the one characteristic symptom that I am significantly interested in is itching, because that tells me whether we're dealing with something which is allergic in nature or not. And the most important aspect of examination is to look at the morphology of the conjunctivitis. And I will be focusing initially on the bilateral cases of chronic conjunctivitis. So as far as morphology is concerned, I've divided it into these 5 forms: papillary, giant papillary, follicular, membranous, and cicatrizing. And under each of these, I've tried to narrow down the differentials based on the various conditions that we routinely see. So let's look at these one by one. Let's start with papillary conjunctivitis. One of the most important causes that leads to papillary conjunctivitis is a moderate to severe dry eye. And talking about dry eye and the manifestations and the disease is probably out of the scope of this particular talk. And I will focus on the various other entities that I have mentioned here. So let's start with superior limbic keratoconjunctivitis. This is a very classic presentation where they present with inflammation below the upper lid, and the upper tarsal conjunctiva is significantly inflamed. You have papillary changes there. And the staining that you see in SLKC is significantly present. You can do a rose Bengal staining and actually stain the area which is inflamed. This is the same patient 3 months later after a very short course of topical steroids, copious lubrication, and the patient is also on topical cyclosporine. You can also have significant conjunctivochalasis. Usually SLKC is associated with both inflammation and chalasis, which is something that you appreciate when you push the lid down. You can actually see the fold of conjunctiva just beneath the upper lid. which is indicative of the presence of chalasis along with the inflammation. And this was one particular patient where we decided to go ahead with an excision of the chalasis because he was extremely symptomatic, and you can actually see the tenting of the conjunctiva when you lift it up with the forceps, which indicates the extent of looseness of the tissue which needs to be excised. And this patient underwent an excision of the excess of conjunctival tissue along with amniotic membrane. And this is the same eye 5 years post-operatively where he's absolutely asymptomatic. And since he started developing similar symptoms in the other eye, he was screened for surgery in the other eye, which he is awaiting. So in general, for SLKC, we adopt a stepwise approach, as I mentioned. We have done very few surgical excisions for the chalatic aspect of either SLKC or chalasis by itself. Apart from the modalities that I mentioned, punctal occlusion of the superior punctum is something that can help the symptoms in these patients by improving the tear lake in the superior cul-de-sac. We use large diameter bandage contact lenses to prevent the rubbing of the upper lid on the superior bulbar conjunctiva. And the last option is surgical excision. In patients with SLKC, we also look for an associated thyroid disorder. The other interesting situation that is associated with papillary conjunctivitis is floppy eyelid syndrome. And as you can see here, the lid easily flips and everts, especially superotemporally. This was a middle-aged, mildly obese gentleman who had been treated elsewhere for almost more than a year with this recurrent episodes of redness that he had. And when you take a history and you probe a little more, he does give you a history of sleeping prone, which is very characteristic in these patients because that's when the eyelid tends to just flip open and there's direct rubbing of the ocular surface on the surface over which they are sleeping. And this is the same eye 1 month later. I've used topical steroids for just a week, but what we did was used a rigid protective shield at bedtime, and just with the use of that, there's a significant amount of improvement in the redness along with the use of lubricants. So this is a situation where you need to ask for the appropriate history, and these are patients who also have a strong association with obstructive sleep apnea. And patching or shielding is the treatment for these patients along with copious lubrication at bedtime, and a permanent surgical approach would be to consider tightening of the upper eyelid by the oculoplasty colleagues. This was an interesting situation, a young child who presented with chronic redness. She had a papillary form of chronic conjunctivitis. Since 1 year, she was on and off on topical steroids. But if you look closely at the eyelashes, she's got a blepharitis with a very classical, what we call as a cylindrical dandruff, and which is characteristic of Demodex. This is another patient who also had a similar picture with a marginal keratitis like episodes that she kept having repeatedly. And when we removed the lashes to check, both these patients had the presence of the mites, the Demodex follicularum in the lashes, which following treatment significantly brought down the inflammation in their eyes. And the treatment that we follow is primarily topical, where we use the tea tree oil treatment either in the clinic or at home, and advise them to keep the lashes clean with regular follow-ups. Moving on to a giant papillary variant of chronic conjunctivitis. The most common cause of conjunctivitis that causes the giant papillary variant is vernal keratoconjunctivitis, or AKC. And apart from that, you can also have contact lens prosthesis or suture-related GPC. So this is a very classical VKC where you have the giant papillae in the upper eyelid, which ends up causing shield ulcers. And in this particular patient, she also had an associated skin allergy for which the dermatologist treated her simultaneously for the skin problem also. The management of VKC and AKC is out of the scope of this talk, but this is the most common disease that causes GPC. And this is the disease where the symptom of itching gives you diagnostic, is of diagnostic value to tell you that you're dealing with an allergic condition. There are certain instances in patients with VKC who have very large exuberant papillae, what we refer to as refractory GPC in VKC. This was one such child where since she did not respond to any of the routine management modalities for VKC that I just highlighted in the previous slide, we actually went ahead and excised the lesions and replaced it with a mucous membrane grafting. And this is the same eye following the procedure. So this is the child that had the mucous membrane grafting, and this is the post-op appearance, the external picture of the eye. This is just, this was another interesting elderly male with a chronic red eye. And this actually happened to be a patient who used to wear contact lenses. And I think the last that he wore it was daily disposable contact lenses. And he wore it more than a month back when he had gone to watch a cricket match. He thought he removed the lenses in both the eyes, but apparently he didn't. He had seen a few ophthalmologists, but when he came to me, he had this redness which had been persistent for more than a month. And you can actually see the rim of the contact lens when you look closely, and you can see the contact lens actually sitting in the eye. He had a small stromal infiltrate which had begun to occur because of the lens. And then once we removed it and treated him, the eye cleared completely. So some of these instances are, just out of the box kind of situations. You just have to examine closely and look for some of these foreign bodies which might be just left in the ocular surface. Moving on to the other important variant of chronic conjunctivitis, which is follicular in variety. This is a picture of follicles. You have follicles in the lower fornix and in the upper lid. So one of the most common causes of follicular conjunctivitis is benign folliculosis, which we see in children, which usually occurs in a quiet eye that does not require any treatment. Inclusion conjunctivitis caused by chlamydia trachomatis is usually associated with inflammation and is one of the most important causes that you need to rule out when you see an adult with a follicular conjunctivitis with a red eye. I treated a couple of patients, though I don't have the pictures of the same, where you need to go ahead and do a conjunctival scraping to look for any inclusion bodies, and also you can isolate the chlamydia in culture or by PCR. Very, very rarely, especially when you have a unilateral follicular conjunctivitis, it might be an indicator of a lymphoma, but that's a very, very rare situation, but something that should be kept in mind. The treatment for adult inclusion conjunctivitis is basically systemic, and azithromycin 1 gram single dose is what is recommended in the form of treatment for these eyes. Molluscum. This is another important cause for follicular conjunctivitis. This patient has multiple lesions, but sometimes you might just have one or two along the lid margin, which are constantly liberating the organisms into the ocular surface, which leads to surface inflammation. And you have to identify and treat the molluscum contagiosum with cryotherapy, and that's how you will resolve the inflammation in the eye. So when we are at it, since we have already spoken about Demodex and molluscum, another entity that can lead to chronic conjunctivitis lies along the lid margins, which also is something which for which you have to epilate or just cut off the lashes, smother the eyelid margins with ointment, and usually it is taken care of. But these are instances where you have to carefully look for these lesions or organisms in the eyelashes. Toxic medicamentosa is another cause for follicular conjunctivitis. This is one eye of the same patient on anti-glaucoma medication. This is the other eye, where you can see there's no staining, but this is the eye that shows almost staining in the inferior 2/3 of the cornea. But I again don't have a very classical picture of toxic medicamentosa, but you have inflammation that's more characteristically along the lower half of the ocular surface. Moving on to membranous variant of chronic conjunctivitis, probably the only one is ligneous conjunctivitis, and usually these patients present with this kind of thick membrane on the palpebral surface, which is normally surgically removed. You can just excise it, and they have to be treated with topical heparin, topical fresh frozen plasma, topical steroids, and topical cyclosporine. 2% is what we normally use in these kids. In the last 20 years, I've seen 4 patients of ligneous conjunctivitis, and it's a manifestation of hypoplasminogenemia, and it can sometimes continue to linger on despite the treatment, especially in children, for months to years before it actually starts settling down. Moving on to another important variant of chronic conjunctivitis is the cicatrizing variety, which again is a very important cause that has to be identified and treated, especially because some of them could be potentially sight threatening. And when you're talking about cicatrizing conjunctivitis, you again need to divide it etiologically into the following. It could be post-infective, post-trachoma, could be post-adenoviral conjunctivitis, which is a very common cause of cicatrizing conjunctivitis that is usually not considered when you see these patients. Of course, immune-mediated forms the most important aspect here with SJS, OCP, and rarely graft versus host disease. Trauma, as in chemical injuries, masquerades, and others such as drug-induced pseudopemphigoid or post-surgical. The importance here is to differentiate between each of these based on the nature of onset and the progression of the cicatrization, the history and relevant investigations. So when you see a patient who presents to you with this kind of cicatrization, where you see some amount of fibrosis and bands of symplepharon and subconjunctival cicatrization, you need to have a plan in your head as to how you're going to go about ruling out each of your diagnosis. So if it's Stevens-Johnson syndrome, you're going to have a classical history of drug reaction of the patient having had a vesicular bullous disease involving the skin and the mucosa, and in the acute situation, it would have been a life-threatening disease. And in the when the patients usually present to you in the chronic ocular stage, apart from the cicatrization, they also have classically features of lid margin keratinization. And one of the important pointers towards SJS is the very acute onset and the classical systemic history. Trachoma is another important cause, especially in our country, for patients who come from endemic regions. Even minimal tracheitic lashes such as these should point towards the possibility of the patient having trachoma. You invert the lid and you see the Arlt's line. These are the Hubbard spits, and very classically on meibography, they usually tend to have a complete wipeout of the Meibomian glands. So this is a slightly more better picture of the Hubbard spits and the Arlt's line, and it's usually associated with cicatricial changes and corneal pannus. And the treatment is to address these sequelae of the disease. With respect to graft versus host disease, you will have an obvious history of bone marrow transplant, and the most common features usually are dry eye, and phonacial shortening is usually very mild. It's more often the subacute or the chronic GVHD. The acute GVHD is rare, but then the picture is usually similar to SJS or 10. Atopy, we already spoke about it. It's associated with skin disease, and you have to treat it in association with a dermatologist. Post-adenoviral conjunctivitis, especially when you have severe pseudomembranes in the acute stage, it's very important to ask the patient whether he or she has had conjunctivitis in the past, whether other family members also had it at the same time. And most of the times, these patients would probably recall when asked that, the dryness or these issues started after they had an episode of conjunctivitis in their eyes or in the family, amongst multiple family members in the family. And when you have these severe pseudomembranes in the acute stage, they can actually, especially when they are present in the superior-temporal quadrant, they can actually cause a scarring of the lacrimal ductules and therefore lead to dry eye. And in these eyes, in most instances, all that they need is a punctal cautery to address the dry eye if the dry eye is very severe. The most important cicatricial disease that one needs to differentiate from SJS and all the other diseases is ocular cicatricial pemphigoid, wherein it has an insidious onset. You could have recurrent episodes of inflammation. You can have associated oral ulcerations. And the most important feature of OCP is the progression of the disease, as I shall show subsequently. And with drug-induced pseudopemphigoid, it's usually secondary to anti-glaucoma medications that lead to these kind of bands, especially in the inferior fornix. And there's a very nice paper that's been written by Guillermo on drug-induced pseudopemphigoid. So these are the lesions that you need to most commonly think of when you're looking at a cicatricial conjunctival disease. And when you want to decide your plan of management, you have to answer a few questions. Is the eye quiet? Is it inflamed? What is the severity of the inflammation? What are the associations? Is there an associated dry eye? Are there in the ocular surface? In SJS, for lid margin keratinization, we normally do a mucous membrane grafting for these eyes to reduce the blink-related microtrauma, as is indicated over here. And visual rehabilitation for end-stage disorders obviously includes the use of various types of keratoprosthesis in these patients. And this is the algorithmic approach to management of SJS, which we have published as a comprehensive approach to the ocular sequelae of patients of Stevens-Johnson syndrome. On the other hand, OCP is an autoimmune disease where, as you can see here, what is most important is serial photographs that you need to look at for documenting progression, because that's the most important way in which you're going to establish your diagnosis. So either a very meticulous drawing or a slit lamp picture with a mandatory 3-month follow-up. And when you see the patient for the first time and you're suspecting a cicatrizing disease, you have to ask yourself whether you're facing a vision-threatening situation or not. If not, then you keep following up the patient every 3 months and look for progression, at which point in time you can subject the patient to a biopsy to know your diagnosis. And if you have a biopsy-proven OCP, or if you have progression in patients with cicatricial conjunctivitis where you are strongly suspecting OCP, then immunosuppression is the treatment for patients of mucous membrane pemphigoid or OCP. And any conjunctival surgery that's done in these patients cannot be done without the cover of systemic immunosuppression now. And this has to be done along with an internist or an immunologist. And this is one of our patients who underwent fornix reconstruction and cataract surgery under systemic steroid and mycophenolate cover. And in the end stage, visual rehabilitation in these eyes is also with the help of the different types of type 2 keratoprosthesis. So it's very important to remember that especially with OCP, it is the use of systemic steroids and immunosuppression, and anything else is a strict no. Deferring or postponing initiation of appropriate immunosuppression is not the treatment in these patients, and if in doubt, always refer the patient to a higher center. I will finish off with the unilateral chronic conjunctivitis variants, which is an interesting subset of chronic conjunctivitis, where the most common causes are probably dacryocystitis and canaliculitis, for which we refer the patients to the oculoplasty colleagues. But you can have, as you can see here, a tarsal foreign body which might be lodged. This is a thorn which was lodged in the upper lid, which usually leaves behind these classical scratch marks on the cornea, and you have to evert the lid to look for these embedded foreign bodies and remove it. Otherwise, the patient continues to keep having the redness. This was a patient, very interesting. He was one-eyed, where he came with this patch of redness and some whitish lesion on the cornea with a very localized area of staining here. And I really didn't know what we were dealing with, but had this doubt as to whether the patient was actually putting his finger inside the eye, especially after looking at the way the staining was taking up on the conjunctival surface. So went ahead and put a large diameter contact lens, as you can see here, and that entire redness, congestion, everything disappeared from here, but he was trying to now push his finger by pushing the lens from the temporal aspect and developed a mild redness on the other side, which made us realize that what we were dealing with was a factitious conjunctivitis, probably Munchausen syndrome, and we also had a psychologist come into the picture to treat the patient. This was a young girl, 12 years, who was treated elsewhere for scleritis, treated with immunosuppression. Biopsy was done. She was started on anti-cox therapy. This is how she presented with this kind of a lesion in the inferior fornix. 1 year later, this is when she came to us. We were also unable to arrive at a diagnosis as to what this was. 1 year later, she had a similar kind of a lesion in the superinasal fornix in the right eye. And we did another biopsy, but it was inconclusive. And when we revisited her history, there was a flare-up every summer vacation. It was the right eye. It was the inferonasal quadrant to start with. She really had no complaints and always came in smiling. And then we doubted whether this was factitious. And when we got the parents and spoke to them, we realized that she had multiple issues at home, and she was trying to do this to prevent them from sending her to the hostel, which is why this kept coming back every time in the summer vacation. And we got her admitted. We did a 24-hour patch, constant surveillance for 5 days in the ward, and within 4 days or 5 days of patching, it completely resolved. Though till the end, she did not reveal to us as to how and what she was doing to cause this in the eye. But this is the same child, absolutely fine, 3 months, happy child after 2 years of ordeal for both the surgeons as well as the family members, and we were extremely happy. Not every story has a happy ending. This was a 35-year-old female who was diagnosed as OCP elsewhere and was being treated for a year like that. And ultimately, when we saw her, these are very, very suspicious lesions. There's keratinization, there's excoriation. And this band was probably what made people think that this was a cicatricial conjunctivitis that they were dealing with. And the other eye was absolutely normal with no evidence of cicatrization. And when we did a mapping biopsy for her, this turned out to be sebaceous gland carcinoma with a pagetoid spread, for which she ultimately required an exenteration. So to summarize, I think we need to have a very clear algorithmic approach in our heads when we see these patients of chronic conjunctivitis, revisit the history when required, keep doing repeated evaluations, take the patient into confidence. Sometimes you just have to tell the patient and the attendant that you don't know what you're dealing with, but you will, need to keep evaluating to know what the problem is. Look out for red flags specific for any of the diseases. Build a rapport with the patient, and if you have any doubt, never hesitate to take a second opinion in these patients. There are a lot of other causes for red eye which can simulate what I have spoken about, but then those are entirely out of the scope of this talk, and I would like to finish this here. If there are any questions, I would like to take them. Thank you so much. I can't hear you, Himanshu. Himanshu, you were saying something?
He's still saying something, but Himanshu's voice is not.
I can't hear you, Himanshu.
There's one question from Dr. Sridhanya. For molluscum contagiosum, is cryo safe over lid? And what about lid margin?
So usually...
Any other treatment option in children, is cryo safe and possible?
Yes, it is. It is an option, and we don't do it. We normally refer the patients to either our oculoplastic colleagues or to the dermatologist, and they do go ahead with cryotherapy for these patients.
That is the only question we have right now. There are so many messages saying that both Dr. Kaab as well as Dr. Geeta's presentation were superb. So I think Dr. Geeta can continue with the second talk.
There's some issue with this. Yeah, can you see the slide?
Yes, it is visible.
Okay, so the next talk that I was asked to speak on was approach to a case of chemical injury. And I think we all know that this basically is one of the very few true ophthalmic emergencies that we see, which can be potentially devastating, that can lead to severe ocular morbidity, and it affects any age group, mostly young adults. And the severity of the chemical injury depends on the toxic agent, the time of contact, the area of contact, the intraocular penetration, and the presence of any other additional mechanisms of injury, such as thermal or mechanical. Between alkali and acids, the alkali injuries cause more damage to the eye because they tend to penetrate inside the eye more. And the most serious alkali injuries are caused by ammonia and sodium hydroxide. And in India, we have this peculiar injury due to the tuna packets, which is caused by calcium hydroxide, which is a very, very severe form of alkali injury that occurs to the eye. Acids also can cause a lot of damage to the ocular surface, and the most common is sulfuric acid, which also causes a lot of additional thermal damage, especially when it occurs because of these car battery explosions. I think when we talk about chemical injuries, it's important to know what stage of the injury you are examining or looking at the patient. So when it's within 2 weeks to 1 month of onset of injury is what we call as the acute stage, when the eye is still inflamed and when you have an epithelial defect. And the chronic stage, as you can see on the right side, is beyond 1 month of onset of injury, when the eye is quiet and the surface is epithelialized, whether it's epithelialized with conjunctival cells because of the limbal stem cell deficiency, or whether there are adequate limbal cells to allow epithelialization with the cornea. Whatever might be the situation, as far as the surface is epithelialized, it's the chronic stage beyond 1 month. And sometimes you might have these semi-acute cases where the shift to the chronic stage has not occurred even beyond 1 month of onset, and you have persistent inflammation and a persistent epithelial defect. So it's important to understand a little bit of the pathophysiology, that the problems that occur in a chemical injury when the chemical comes into contact with the ocular surface is because the epithelium has been lost, both the corneal as well as the conjunctival, because of which you have access of the inflammatory mediators to the underlying stroma, which is basically what leads to the haze, the stromal haze and the ground glass appearance. And ultimately, over the next few days, it can lead to a stromal melt. And if the circumstances permit, then you can have a secondary infection in these eyes because you don't have an epithelial cover. If you need the epithelium to regenerate, you need stem cells both corneal as well as conjunctival, and because the chemical damages both your limbal stem cells as well as the conjunctival stem cells, which are located at the fornix probably, the regenerative capacity is compromised. You have a loss of the limbal barrier, And in addition to these two pathologies that are occurring in the ocular surface, you can also have damage to the vessels, which leads to ischemia, which further impedes the re-epithelialization process. So understanding this, we define the goals in management of acute chemical injury, which are basically to get rid of any residual chemical in the eye so that it does not continue to damage the ocular surface. You try and retain or regain the function of stem cells if possible. You retain a relatively clear corneal stroma as much as possible, for which you need to get back the epithelial cover as quickly as possible. You try to overcome the phoneal shortening, because nature's attempt to salvage the anatomical integrity of the globe is to quickly shut down the ocular surface, which is why you see the significant symblepharon. And of course, you have the raw surfaces on both the palpebral as well as the ocular surface. And you want to, under every cost, prevent sight-threatening complications. And to achieve all this, you need to have a very quick epithelialization of the ocular surface. Keeping which in mind, we devised what is called as the I's and E's in the management of acute chemical injury, which helps us go in a very algorithmic way, making sure that you have not missed anything in the process of examination. So the first I is the inciting agent, which is treated by irrigation. So that's the I's of the management, the first I in the management. When the patient presents to you in the emergency, if it's an acute chemical injury, take a short, quick history. Ascertain what the nature of the chemical is, if the patient is aware whether it was an acid or an alkali, what has been the duration since the episode, how many hours or how many days, whether primary care, if any, was given, especially wash, and was there any associated mechanical injury, if any, for example, a car battery explosion. Do a cursory torchlight examination, rule out a globe rupture, which is usually very, very rare in patients with chemical injuries. Do a pH check with the litmus strip as shown here in the inferior fornix. And ascertain whether you're dealing with an acidic or an alkaline ocular surface. You are not going to spend any time here doing a vision check. You will start the wash even before you do the vision check. And to do the wash, you will use irrigating or rinsing solutions that is available to you. We normally prefer ringer lactate over 0.9% saline solution. You have buffering solutions. You can have amphoteric substances which work on both acids and bases. But in the emergency situation, either RL or normal saline, whatever is available to you, if RL, preferably RL, just use that to start irrigating the ocular surface. If it's a non-medical setup, just tap water is enough to copiously irrigate the ocular surface. So when you are in the emergency taking care of this particular patient, the choice of aqueous solution, if available, yes, but it is of less prognostic importance than the timing of the treatment, and any delay in irrigation should be avoided in these patients. So how do you irrigate? You put in a topical anesthetic, place a speculum. If it's a bilateral injury, you do a simultaneous wash in both the eyes using either ringer lactate or normal saline. Recheck the pH every 5 minutes during the wash. This is the Morgan lens, which has been classically described to be able to reach up to the depths of the fornices also. But even if you don't have that, you just wash thoroughly using the speculum. Rinsing should last at least 15 minutes. Use as much of the irrigating solution that you need so that the pH comes down to between 7 and 8 in the lower fornix. The issue with tap water is the plus side is that it can penetrate the cornea and actually dilute the offending agent, but the negative side to it is that it increases the edema and the corneal clouding with the cell lysis, which is the reason that you prefer the other solutions. In case of tuna injury or blasts, you have to double evert the lid to remove any chunk of tuna or debris which is there in the upper fornix. Once you have done this wash, your subsequent evaluation in the emergency would include a vision check, a slit lamp examination, a fluorescein staining of the ocular surface to assess the extent of the epithelial defect, the corneal, the conjunctival, both bulbar and the tarsal surface, do a detailed meticulous documentation, have a nice slit lamp drawing which shows exactly the extent of the ocular epithelial defect, and then you document the corneal status, the presence or absence of corneal edema, presence of any stromal thinning. Sometimes you can have then you also need to specifically look for the clock hours of limbal staining, as I shall show subsequently, the presence or absence of scleral ischemia. Look at the anterior chamber details, how well you're able to see them, and if there's anything specific that needs to be noted. The finger tension has to be assessed in these eyes. Look for presence of lid injuries, the extent of raw surface involving the lid margins, the external eyelid, the cheeks and the face. Draw a face picture if there are any facial injuries. Look for lid closure, whether it's complete or not. This is extremely important because you don't want the eye to remain partially open and the patient to end up having a corneal melt because of that. Any other life-threatening injuries, obviously you would have looked as soon as the patient came into the emergency, and a medico-legal consent has to be taken in cases of vitriolage. So once you have finished with the initial part of irrigation and examination, the next eye that we're going to be focusing upon is the ocular surface inflammation, for which the mainstay of treatment is by the use of topical corticosteroids, which is started immediately after the chemical injury, though the classical teaching is that we should use it for 7 days and then probably, kind of consider stopping it or tapering it. It is not that you have to abruptly stop it. It can be continued subsequently, but you have to simultaneously address the epithelial defect, because that's when the complications of a persistent epithelial defect start setting in the form of a stromal melt, which can be aggravated by topical steroids if you use it over an epithelial defect. The other medications which help reduce the inflammation-induced stromal melt are doxycycline, topical citrate, and topical ascorbate. If you have the lab facility to reconstitute it, it can reduce your inflammation. But if you don't, then systemic ascorbate should be administered to the patient of up to 2 grams per day to be continued over the next 2 weeks or more as the need be. The additional medications that are prescribed at this time are cycloplegics, broad-spectrum antibiotics, and lubrication. And once the inflammation has been taken care of with all the medications that I have just mentioned, probably the most important aspect that needs to be addressed in a patient of chemical injury is the epithelial defect. That is the first E of the eyes and E's. And for this, usually we place a bandage contact lens in the eye. You have large diameter lenses up to 18 millimeters which are available. So even on day 1, when you see the patient, unless the defect is a very small defect which is only involving your cornea, and there's no other external injury, and you think that by patching for a day or 2 things should settle down, it is preferable to use a contact lens so that you can address the other issues by starting the patient on topical steroids and the other topical medications that are required, and simultaneously keep examining these patients. When you have a defect which does not heal even with the initial medical management that you have initiated, is when you start thinking of the subsequent modalities, which are basically amniotic membrane, which provides a basement membrane for the residual epithelial cells to proliferate. It also has an additional role in abating surface inflammation. But what is important to remember is that there is a role of amniotic membrane only if you have residual epithelial cells on the ocular surface. So when you have a very severe grade injury where you have an epithelial defect that is involving the entire tarsal surface and the ocular surface, and it's probably damaged a significant proportion of your stem cells, and you don't have residual cells to regenerate, the amniotic membrane is not in a position to provide you with cells. It can only provide you with the basement membrane. And that is why when you have very severe chemical injuries and you have delayed epithelialization of the cornea, you end up seeing a lot of these complications where the central part of the cornea, which is the last to epithelialize, ends up with either a stromal melt or a stromal scarring, or in certain cases even with a perforation, which ultimately requires a tectonic penetrating or lamellar keratoplasty in the acute stage, or a similar keratoplasty in the chronic stage for visual rehabilitation. And precisely to avoid this and to help the surface heal faster, when you have a very severe grade of chemical injury along with the amniotic membrane, you also have to provide the ocular surface with an alternate source of cells, which could be in the form of either a mucous membrane from the patient's own oral mucosa, or you can provide cells from an allolimbal graft, which is what is called as alloslet, and is advocated for very severe chemical injuries which do not show any evidence of healing in the first few days with just your medical management and even one trial of amniotic membrane, which is what we described in our paper that introduced the concept of alloslet in the early stage of ocular chemical injury, which is very similar to the autoslet that has been described in literature by Professor Sangwan. And it's basically the same technique, but only thing we use allograft from the cadaver limbal stem cells, whereby we aim to achieve quick epithelialization of the ocular surface, so that once you have an epithelial cover on the cornea, you don't have inflammatory mediators getting into the stroma, leading to the haze or a possible melt or a possible infection. And subsequently, when the allo cells which you have transplanted fail, because they will, because you are not going to put these patients on immunosuppression, especially if it's a unilateral injury, you anticipate these allo cells to fail, and just at the time that you would do an autoslet otherwise in these patients at around 4 to 6 months after the injury, you do an autoslet when the allo cells start failing. So what we have seen is there is a lesser need for subsequent PK or LK due to lesser stromal scarring in these patients. There's a faster visual rehabilitation, and there's a lesser possibility of occurrence of amblyopia in children because they start seeing much earlier. So these are some of the case illustrations where we have used alloslet in the acute stage, followed by autoslet in the chronic stage. And this is another one of our patients where you can see the patient is maintaining a vision of 6/9, actually now almost more than 4 years after the injury. It's the left eye that's injured, where this was the presenting feature, and the patient continues to see 6/9 in the eye after an alloslet in the acute stage and an autoslet in the chronic stage. Another important factor which we sometimes miss in the acute stage is to look for ischemia, which has to be specifically looked for. So if it is scleral ischemia, so if it's localized, you can observe the area of ischemia, but if it's generalized, then these are patients who require the ischemia to be addressed, because you will then end up with complications such as corneal stromal melt. Again, ischemia can delay or prevent epithelialization because you don't have a vascular bed, and you can also have an associative severe hypotony in these patients. And when you have ischemia that needs to be addressed, we normally do that with a tenonplasty by the technique which has been described by Rime et al., where we mobilize the tenons from the equator and secure it at the limbus using vicryl sutures, and then place amniotic membrane over the entire surface. The next eye that needs to be addressed is the intraocular pressure, which, if high, needs to be treated with systemic acetazolamide. We try to prevent the use of topical anti-glaucoma medications in the acute chemical injury stage. And if it's low, then we start these patients on systemic steroids along with the systemic ascorbate. And either ways, it needs an appropriate timely management. Exposure is probably one of the most underemphasized points in management of acute chemical injury, because if you, especially with acid injuries, you end up having this kind of an eschar, which prevents the eyelids from moving, and it prevents the eyelids from shutting down. And these patients require a cut down of the eschar along with a skin graft. And just a simple tarsorrhaphy is all that's required in these patients if you are planning to refer the patient across, so that there is no perforation that occurs by the time the patient reaches a higher center. The ultimate caveat in managing these patients with chemical injuries is that corneal perforation has to be avoided at all costs, because it totally changes your prognosis, it totally changes your management in these eyes. And a simple temporary tarsorrhaphy before referring the patient to the higher center in the presence of an epithelial defect is all that's required. Just take or 3 sutures and zipper the lid before you send the patient across if the patient has an linear total corneal epithelial defect, if you cannot do the other means which have been described. So when the patient has a thinning, then what we normally do is we either plan for a multi-layered amniotic membrane or a cyanoacrylate glue application, or if the perforation has already occurred, if it's small, then we go ahead with a tectonic lamellar keratoplasty or a penetrating keratoplasty addressed systematically, and you follow this concoction of medications in the initial management along with the addressal of the eyes and E's, then you will have a good outcome in these patients. And the pertinent points which I would like to re-stress upon is that in case of a line injury, GA exam is mandatory. It is mandatory for children as well as for adults who are not cooperative for examination, because this is how you have the tuna being trapped in the upper fornix, and this keeps releasing the alkali into the ocular surface, and you end up with severe damage to the ocular surface. So every child, every adult, every patient who has a tuna injury should be subjected to a mandatory GA examination in order to clear this and excise this lime that gets deposited in the upper fornix. And this is the same patient after multiple interventions, after all the steps of addressal of eyes and E's have been done in the acute stage. If there's a plaque, we do attempt to remove the plaque also. And even if you're putting a PCL in the eye, these patients have to come back to you for a daily review, because you have to grade these patients even when they are, when you see them on day 1. And it is the Duas classification that we routinely follow, where we mention the amount of limbal involvement and the percentage of conjunctival involvement. As mentioned here, the percentage of epithelial defect and the clock hours of limbal staining. This is a dynamic grading which changes with treatment. It indicates what the effect of your management is, whether it is improving or worsening. It dictates the course and change of treatment, and you have to document the grade every day when you assess these patients. And this is what we tried to emphasize in this paper, where we spoke about the algorithmic approach to management of patients, where each and every I and E has an effect on the epithelial defect, which in turn has an effect on the complications that you encounter in patients of chemical injuries. And this is an algorithmic approach to each of those parameters and how you will go ahead treating each of these based on the extent of damage that has occurred to the ocular surface. So the goals that you had set when you started off, you will achieve most of these with a good outcome by addressing the eyes and E's. And it's equally important to remember that you have to counsel the family and the patient that the primary aim of treatment in the acute stage is only to heal the ocular surface, and you have to explain to them that the visual and cosmetic prognosis is something which can be determined only after the eye goes into the chronic stage, and there's a possible need for multiple surgeries with regular follow-ups. Because when you have a patient who comes to you like this, which is actually almost close to a grade 6 chemical injury, in the absence of corneal clouding and presence of an epithelial defect on day 1, the vision that is documented in the acute stage is always good. Patient will be reading 6/6 when the patient comes to the emergency, but has a 360-degree scleral ischemia, which is an ominous sign. A white eye in chemical injury is an ominous sign. And when you treat this patient subsequently, this is the way the eye will vascularize and conjunctivalize, and there's a progressive decrease of vision which occurs, which many a times the patients and family wrongly attribute to the management by the ophthalmologists rather than to the injury. And in this particular patient, ultimately required a type 1 keratoprosthesis, with which he has been maintaining a vision of 6/6 because he had a similar grade injury in the other eye also with ammonia. So basically, in the acute stage, the aim is to salvage the globe and salvage the stem cells to the extent that is possible. And very briefly, to touch upon the management in the chronic stage is based on the extent of limbal stem cell deficiency. Based on that, we have an algorithm to treat these patients based on the laterality and the tear film status. So if it's a total limbal stem cell unilateral deficiency, then SLET is the most recommended form of treatment. And if it's bilateral, we have multiple choices and keratoprosthesis to choose from today, we have various options, and these are summarized in the review article on keratoprosthesis in the IGO, which we published a couple of years back. And these are some of the patients with chemical injuries where you can see from the acute stage to the end point and the multiple years of follow-up thereafter, maintaining good vision with the different types of keratoprosthesis that are available as of today to treat these patients. So the one thing that I always say is that since we have so many options which are available for visual rehabilitation in the chronic stage of severe bilateral chemical injuries, every chemical injury in the acute stage should be managed aggressively with the sole aim of preventing corneal perforation and any other complications. And severe cases should be referred to tertiary centers when required. And a simple tarsography before referring could reduce the risk of perforation in eyes with exposure and large epithelial defects. It's the management in the acute stage that determines the long-term outcome and prognosis. You can transform the lives of patients, and if managed well in the acute stage, she presented to us like this. We had to struggle to get her back to some amount of normalcy. She had a retinal detachment in the eye, and she now, 5 years later, is working as a teacher in the school. And you can really bring about a change in the lives of these individuals. Thank you.
Yeah, Dr. Geeta, that was an excellent presentation, very comprehensive. Sujit, do we have any questions? I don't see anything in the chat box at present.
No, I think we don't have any.
Okay. So shall we invite Himanshu for his next talk? So Himanshu, your audio is, there is some problem with the audio in your side.
Himanshu, can you try connecting your, are you using headphones? Okay. We'll try to rejoin. I have a case to present. If Himanshu is taking time, can I utilize this time to?
Yeah, I think that is a good idea. Yeah.
Dr. Geeta, it will be related to your topic. Let us see if Himanshu is continuing.
Sujit, am I audible now?
Yes, you are audible. Yes.
Okay. So I'm going to share the screen. Is this my slides are visible?
Yeah.
Yes, all fine. Yeah.
And my audio is also audible, right?
Perfect.
Yeah. Great. Thank you. Thank you, Sujit, for this wonderful opportunity to again catch up with you all, guys. I think most of my friends are from Kerala, and Kerala Ophthalmic Society is the one which I end up attending more often than the Karnataka Ophthalmic Society conferences. But well, thanks to you all. So I'm going to start my topic with a few mistakes which we commit, which we all commit in our dry eye management, and I'm going to take one by one. These are the things which are not, I wouldn't say a mistake, but that's related to the misconception in our entire science of dry eye. And I call dry eye science a very skewed science because the way we define dry eye is very, very different. So let's start with the first one. First is the classification of dry eye into aqueous deficient and evaporative dry eye. Whether it's due to which ultimately defines it as an aqueous deficient or evaporative, or whether it's an Asia Cornea Society, which ultimately again ends up classifying into aqueous deficient or the evaporative or poor wettability, what they call. All these things, they basically defining dry eye into two major components, aqueous deficient and evaporative. But by doing this thing, are we actually classifying dry eye based on the root cause or just the effect? And unfortunately, we are doing the classification based on the effect of the disease and not the root cause of the disease. If you look at the dry eyes, do you think the dry eye, which is related to a rheumatoid arthritis, would be same as dry eye related to MGD just because their Schirmer's values are equal and low? Well, of course not. We know that. Shouldn't we be treating the root cause and the root problem and not the effect? Well, unfortunately, in the dry eye, when we call signs of dry eye and when we see the damage has already occurred and it's already irreversible damage most of the time. If we look at an example of GVHD. Now, GVHD typically occurs with the allogenic stem cell transplant on bone marrow transplant. And according to one study, more than 60% would end up in dry eye. But in my experience, where I closely work with the bone marrow transplant unit, most of the patients at some point of time in their life, they do end up in GVHD. So the problem is that in spite of very high probability of dry eye due to the GVHD, we would not call it disease or we would not call it dry eye till we see the sign of damage. And when we see the sign of damage, we will tell them that, you know what, the dry eye because of the damage to your lacrimal gland is irreversible and will not be able to do anything. Whatever is lost is lost. So that means we waited for it to get damaged and then we are telling them now it is damaged. So this is like that old advertisement which we used to see where a small kid is sitting there near a tree and a guy is backing up his car and he's asking, just have a look, is it touching? Is it touching? And then he said, yeah, now it's touched. So this is exactly what we are doing in dry eye management. We wait for damage to occur. So you think about a person who has undergone bone marrow transplant, comes to us, and we'll look at his surface and we'll look at the Schirmer's value, you look at everything and you will tell them, you know what, there is no damage, so you don't have dry eye. But we know that by the time you see the damage, it's already lost game. So such kind of cases, wherever we know that there is certainly going to be an inflammatory damage, like as I described, allogenic bone marrow transplant, somebody with autoimmune disease, somebody with Sjogren's syndrome, thyroid dysfunction, OCP, such kind of cases, the dry eye, which is going to be inflammatory dry eye, we must start anti-inflammatory much before we see the damage. And all these anti-inflammatory, we know whether it's a cyclosporin or tacrolimus, they have very wide therapeutic window and hence we can safely start them. Coming to the mistake number 2, the most important test for dry eye diagnosis is Schirmer's test. Most of the time when we get a referred case, we get like Schirmer's normal, Schirmer's that too without anesthesia. And Schirmer's normal value does not actually mean anything to me. Frankly speaking, there is certain thing which even if we look at the diagnostic criteria, most of the dry eye diagnostic criteria confirms that the gold standard is questionnaire, quality of vision, BUT, and Schirmer's test. But if you look at any of these things, are we actually able to find out the root cause? Or we are just seeing the effect. And unfortunately, we are just seeing the effect. So none of these things actually tell us about the root cause. So what are we doing to look at the effect? Well, very interestingly, the Asia Dry Eye Society came up with a pattern of tear film breakup time, which had some correlation with the disease. Whether you have some particular type of pattern, whether it's an area break or whether it's a spot break, which is related to operative dry eye, or area break, which is related to severe aqueous deficient dry eye, or linear break related to aqueous deficient dry eye. But that's very interesting. The test is very simple and we surely can introduce in our clinical science. But is it so repeatable in every society? Unfortunately not. Our eyes do not always show such kind of pattern, but that's very interesting part that not just Schirmer's test, your tear film breakup time is something which is very, very important and we do not give that as importance as we normally should have given. Mistake number 3, the frequency of lubricant 4 times a day. Somehow we all ophthalmologists are tuned to give every lubricant 4 times a day. There's no logic behind that. Now the question arises, how long a drug stays on the ocular surface, and that's called ocular surface resident time. And that depends upon the rheological property of lubricant, that's viscosity, the blink rate of the person, the temperature of ocular surface, the pH of the surface, as well as the lubricant, the TFM clearance time, the adsorption of lubricant on surface, as well as the evaporation rate. And you know that every individual, these things would not be same. So a different individual, a same lubricant may not have same amount of ocular surface resident time. Interestingly, from Anthony Braun's group, they had done very good study on ocular surface resident time of spatially related to the artificial tear solutions. Using direct and indirect method, they measured the half time. Please remember, the complete time cannot be measured, because at the end of the fag end of the time where the molecule is on surface, it may not be in a decent amount to detect, or it may not be even effective enough that time. So usually we talk about the half-life. Now the half-life of very viscous lubricant, what we are told now is sodium hyaluronate 0.2% was 5.5 minutes. And that means even if you double it, which is not true, that the total time would not be more than 10 minutes or 15 minutes. And this is about sodium hyaluronate. Something like HPMC is 44 seconds. And if you look at such kind of lubricant, if you give them 4 times in a day, tell me, how do you expect any improvement, which is absolutely absurd according to me. Whenever we give anything which is 4 times a day, to me, it's more psychological. If you have to give somebody lubricant, give more frequently, and need not to be exactly hourly. I mean, it need not to be exactly 2 hours on your watch. Well, it can be more often when they are doing some attentive activity or their high risk activity. Later on, they can have less frequent. So let's not be rigid in terms of the frequency, but let's remember that giving 4 times a day lubricant is actually totally useless. Mistake number 4, benzalkonium chloride or BAC. We love to hate this guy, and this is the best villain we have in our ocular surface. I do agree that it is severely surface toxic or epithelial toxic. But when you're using a drop which is 4 to 6 times a day, it hardly matters. And also somebody who has a decent ocular surface or tear film turnover, within 30 seconds, it would dilute 8 times, and within 1 minute, 16 times, and within 3 minutes, it's diluted 36 times. I mean, it's hardly anything there on the surface. So if somebody's ocular surface is already damaged, or they are on multiple medication, or they have punctum occluded, in those cases, yes, I agree. But if you are using a drop which is 4 to 6 times a day, well, it's not as bad as we think. But of course, I don't say that we must use benzalkonium chloride, but preservatives are not as bad in your routine scenario. Mistake number 5, lubricants must have all the electrolytes, and we keep on getting new drops which tells us that we have every electrolyte possible. What are the use of these electrolytes? Well, these electrolytes, something like sodium, which is very important for maintaining osmolarity. Potassium is important for the health of goblet cell and glycogen. Bicarbonate is essential part of maintaining the epithelium integrity as well as the health of the epithelium, and it helps in healing. But unfortunately, this bicarbonate is unstable compound, and especially when you are using multi-dose vial, the bicarbonate gets converted into carbon dioxide, and which does not stay there long. So in multi-dose vial, bicarbonate does not help you much. Look at the sodium part of it. Now, when we say sodium is required for our osmolarity, remember one thing, the increase in the sodium level does not mean it's going to be better. In fact, the study with carbomer and sodium combination found that increasing sodium actually reduced the viscosity of carbomer. So just increasing addition of a saline in the treatment, some of the ophthalmologists, especially in countries like Japan, they like to use isotonic saline as a hydrating agent, but unfortunately not always that helps. Mistake number 6, higher viscosity, better the lubricant. And this is something which we love to talk about. Anytime, whenever we talk about lubricant, we talk about the viscoelastic agent, but that's just one part of the lubricant. What does these things do, viscoelastic agent? Well, it actually increases the surface retention time. Higher molecular weight will lead to longer retention on the surface, but as I discussed earlier, there are many other reasons why it should stay on the surface or it should not stay on the surface. But higher molecular weight can also have crusting, which can lead to foreign body sensation when those crusts fall inside the eye. The lower molecular weight may be less viscous, but remember, somebody who is just mildly symptomatic might be actually more comfortable with low molecular weight viscoelastic agent than very high viscoelastic agent. So always higher viscoelastic agents are not best. Now, the viscoelastic agent, when we talk about, we like CMC and all those things, but because of the price control in our country related to CMC compounds, now every company is pushing the compounds like PVAs and polyols and all those things back to us. It's more of an industry related push. But remember, like some of the compounds like polyols, they are natively not as viscous unless they're combined with HP-GUR. When we look at these things, we'll look at them later on. Telling patient, mistake number 7, telling patient or not telling patient to refrigerate the lubrication. Now, why does these things require to be lubricated? Remember, the viscoelasticity or viscosity also depends upon the temperature. More the temperature reduces the viscosity. Certain agents like carmelos and hypermelos, they do not have enough viscosity at even your normal body temperature. And things like sodium hyaluronate or even CMC, when the temperature increases, and especially countries like us where we have temperatures in our ambient temperature can be like in 40s or something, the viscosity of such agent can significantly go down. So simple suggestion of asking them to refrigerate these compounds can actually maintain their viscosity, can increase the ocular surface resident time. The next mistake, combining different lubricant. Just to give an example, I'm using Cysteine Ultra name, but I do not have any disclosure here. Now, combining something like Cysteine Ultra with aminoglycoside cyclopentolate. What I mean by here is now I'm referring to pH part of it. As I discussed earlier, the pH is also something which decides the ocular surface resident time or effectiveness or the viscosity of the drop. Now, something like HP-GUR, which is integral part of the viscosity of something like Cysteine Ultra, the HP-GUR is liquid when the pH is acidic. And when the pH becomes basic, more than 7.5, it becomes gel. The antibiotics like aminoglycoside, they only work when the pH is acidic. So if the effect of antibiotic has to be there, the pH of the surface has to be acidic, and that's why these antibiotics are acidic. So if in a case of conjunctivitis or in a case of microbial keratitis, if you combine these two together, either your antibiotic is not going to have effectiveness or your lubricant may not have the viscosity. So combining such medications may not be the best thing. So which are the other medications which can have acidic pH? Cyclopentolate, very significant acidic pH. Tropicamide, ofloxacin, lid patching, all those things can lead to acidic pH. And when you combine such kind of thing with something like Cysteine Ultra, well, you are not getting the viscosity of the medication. Hence, it may not be the best idea to combine these two. Some things like PVA, if they are mixed with certain gel, or sodium bicarbonate or sodium perborate, they end up having a thick, gooey material kind of thing, which is not very comfortable on surface and does not have very good surface coating time. CMC, when they combine with certain metabolites, so when typically multi-drug treatment, it can lead to insoluble precipitates, and more so with 1% CMC. So such kind of cases, we can avoid CMC when you're using multi-drug treatment. And as I said, HP guar does not remain liquid when the pH is less than 7. Next mistake we make is osmolarity, where we are taught that osmolarity is most important thing in terms of pathogenesis of dry eye, which is true. I do agree with that. But when we talk about measuring the osmolarity called osmometry, that's where our science falters. That when the osmolarity is checked on the surface, the range what we are told, the normal range is somewhere around 300 milliosmol per liter. But if you look at the normal data also, there's a huge crossover between normal and dry eye cases. So a case with the dry eye can have normal osmolarity, and case with normal eyes can have abnormal osmolarity. Also, on the top of that, the machine is pretty expensive. Also, if you look at the repeatability is very good when the osmolarity is normal or the normal patient. But more the severe dry eye, the variability or repeatability is severely affected. So if you look at the literature, there are interesting articles about dry eye being showing normal osmolarity compared to the normal cases. So dry eye osmolarity or normal cases osmolarity, both of them were same. Cases with Sjogren syndrome or non-Sjogren syndrome and normal, all of them, they had similar osmolarity. So osmolarity per se does not actually give you a diagnosis. Also, there are certain interesting things which we have to remember about osmolarity. The osmolarity is a dynamic thing. With each blink, the osmolarity changes and it varies in significant amount. The sample what we collect is from lower tier meniscus, and the osmolarity is not equal in entire eye. In fact, the most important place for us is the central part of cornea, where we do not measure. Most of the studies, when they have done ex vivo studies, they are not reliable. And even if we have hyperosmolarity, hypoosmolar agents, which were there earlier in the market, and as I told you, many surgeons, many ophthalmologists like to use isotonic saline or normal saline solution to hydrate the surface to reduce osmolarity. Interestingly, within a minute or two, this osmolarity comes back to the previous level as it was before the drops. So using hypoosmolar does not help you. So if I have to summarize the osmolarity, well, osmolarity is important thing, but increased osmolarity is important part of the dry eye, but unfortunately we are not able to measure it correctly. So we have to accept the hyperosmolarity per se. So how do you deal with that? Well, in that case, there are certain compatible solutes or osmoprotecting agents which are used by pharmaceutical industry like L-carnitine, erythritol, glycerol, trehalose. These things help you to reduce the cell damage on the surface of such kind of dry eye. Hence, even if the osmolarity is high, it can reduce the surface damage. So any of lubricant which you use, we wish that they should have osmoprotecting agents. We know about these osmoprotecting agents. So ultimately for osmolarity, well, we cannot deal with changing the osmolarity, but we can possibly deal with protecting our surface with osmolarity. Coming to the 10th mistake, every MGD should be treated with LipiFlow or warm compresses lead massage. Well, we know that meibography is something which is extremely important nowadays in treating the dry eye, especially the evaporative dry eye. The normal meibography shows vertical orientation of the glands, and in abnormal cases, you may see either convoluted glands or you may see loss of glands in some areas. I've been doing meibography since very, very long time using a simple autorefractometer where there were no meimographers available. The autorefractometer with its infrared light, gives you absolutely beautiful mammography. Unfortunately, you have to use your smartphone camera to capture that, but any IR source in that sense can be a help. Not all the machines are actually able to give you a good IR image to delineate the Meibomian glands. So you can try out different instruments in your OPD, and you may find out something which works for you. Why is it important to measure the mammography? Well, the current practice, what we were taught, that when we see clinical diagnosis of Meibomian gland blocked or Meibomitis, we treat them with warm compressive lid massage. But when you check them with the mammography, and when you see the Meibomian glands are present, well, this thing is going to work. But when you check them, that if Meibomian glands are absent or there are loss of glands, even if you keep jumping on the eyelid, nothing is going to come out because glands are lost. In such kind of cases, whether we do lipiflow or we do iLux or anything to express the Meibomian secretion, it's not going to help. So before doing any of such kind of thing, you must do a mammography. This is my own mother's mammography. I've taken her permission for this thing. She used to complain about severe dry eye, and I always, as we all do, our family members, that we don't give them too much importance, that, you know what, lubricant and all those things, till she came to me, and when I did her mammography and realized that she hardly had any Meibomian gland left in her either eyes. So such kind of cases, the best lubricant has to be something which is oil and water emulsion. And unfortunately, in the drop form, we do not have much option in our country. And hence, we may have to use paraffin-based ointment, something like Equilib PM or Cornigel in our country. Especially cases like Stevens-Johnson syndrome, when they have severe Meibomian gland loss, drop off or rather treatment with Cornigel or Equilib based on paraffin-based lubricant would be a life-changing treatment for them. I said 10, but well, who doesn't like a bonus? I'm going to just close down with a bonus, which is punctum plug. In our country, somehow we just don't like punctum plug, and where across the world punctum plugs are widely used. There is enough evidence in our literature which shows that with the punctum plug versus placebo, or rather punctum plug versus lubricant alone, there is significant improvement with symptoms, with Schirmer scores, as well as TFM stability in favor of punctum plug. It's not just used for dry eye, it's used for PEDs, it's used for non-healing epithelial defect. Geeta said superior limbic keratoconjunctivitis, filamentary keratitis, along with the refractive surgery, non-healing neurotropic defect, lid viper epitheliopathy, recurrent corneal erosion, contact lens intolerance, and somebody where you don't want systemic absorption of the medications. However, most important thing when we talk about punctum plug is sizing. If we do not do proper sizing, it's not going to help us.
The video is not visible.
Oh, video is not visible? Okay,
yeah,
fine.
This is one mistake which we do in webinars because the audio in the video is never audible.
Okay, sure. Not a problem. I'll take up...
Your audio is also breaking.
Okay. So basically, there are certain punctum sizes which are available. Now, we do have one such Vera punctum sizer, which is widely available in our market, India. So basically, it's like like a rod kind of thing, our lacrimal probe kind of thing. which has on one side diameter which is 0.8, and the other side with diameter which is 0.6. So what happens is when you put a 0.6 plug inside, 0.6 diameter rod inside, if it goes, if it doesn't go inside the punctum, that means the punctum is very small, and you may have to use small size punctum plug. Then if you put the 0.6 and if it goes inside easily, then you turn towards the opposite side, which has a 0.8 millimeter in diameter. When you put it inside, if snugly fits, well, you can go for the medium size, and that's absolutely fine. But if the 0.8 also easily goes inside, that means you may need a larger punctum plug. And if you do not follow the sizing, you may have more chance of extrusion, which is the commonest thing where we do not like to use punctum plug. Most of the time, this is the flow chart which I would like to leave you with finally, where you have a patient where you think about doing punctum plug. First, do a lacrimal sac syringing. If there is any blockage of the passage, please avoid plugs. If the syringing is patent, you can use temporary collagen plug. These are very cheaply available. In fact, they can be as cheap as probably 100 rupees or so. And they're very widely available with us. So you can put a temporary plug and see the response. Usually they stay for probably 3 to 4 days time. And after that, if patient says that they had significant or he or she had significant epiphora, well, we may want to avoid the plug. But if patient was comfortable, you can use extended plug. Now, these extended temporary plugs are also quite cheaply available and which may work for almost 3 to 6 months. Different companies have different claims. Now, this significantly gives you a window period when patient can decide about the permanent plugging or not. If patient has any complication, well, you avoid it. If patient was comfortable, either you can repeat it or you can put a permanent plug. If patient has very severe dry eye, as Geeta was showing, a punctum cautery would not be a bad idea. So with this thing, I would close my topic. If there are any questions in comment, I'd be more than happy to take.
We have a question from Dr. Vijayalakshmi. Normally, how long do we get symptom-free period after treatment with warm compresses and mechanical massage?
Okay, so that depends on how it's done. So if you are using, say, LipiFlow kind of devices on some mechanical device with the thermal pulsation, where you do see the response very fast. In fact, within a day or two, patient would feel much comfortable. In fact, when I tried on myself, I was comfortable on the day of the treatment alone. But the thing is, the longevity of such kind of treatment is not very great. So even if patient feels comfortable with such kind of thermal pulsation and massage, after some time you may have to repeat it. Now, talking about the warm compresses and lid massage with your finger lid massage, it depends on how comfortable the person is with the massaging. A lot of time they just rub their eyes and touch their skin rather than doing a proper nice massage. And for that particular reason, a lot of us do an office expression of Meibom, where very simple forceps we use and we express the Meibom in the office. And especially those who have chronic symptom, we prefer that. But otherwise, we normally, it's very individual and depends upon how bad the MGD is.
Okay, Vinay, any other questions for Dr. Himanshu or any other speakers?
No, nice presentations. I mean, huge topics, but all of them really did justice to it.
Yeah, we are slightly overshooting our time. So I have a small case for presentation. Actually, I don't have the complete details. Whatever details I'm having, I'll share. It's related to Dr. Geeta's topic. Hope it is visible, the slides.
Yes, it is visible.
Yes, yes.
Okay, I'll just rush through the valid points. So this 70-year-old male patient was referred from an Apex Institute, and he was a one-eyed patient. He was referred because he couldn't travel all that far, and he was staying close to my place. So he has actually lost one eye even after exanthematous fever in childhood. We don't know the details of what actually happened. He was having very good vision as per the patient in the seeing eye till recently. So he was diagnosed as having glaucoma, and he was on anti-glaucoma medications. All the previous records were not accessible for me, but I got the reports a few reports from the referring center, and further reports I awaited. In March 2019, he was having 618 best-corrected vision. In April, he was having 624. Then he went somewhere else from that institute and underwent cataract surgery. He came back to that institute in December 2019 with a vision of by 6. He also, in his history, says that the vision blurred. I mean, after the cataract surgery, there was sudden decrease in the vision. So at presently, this was the clinical picture. The eye was looking it was very angry looking eye. It was pseudophakic, but this clear see that eye will shine, but other details was not visible. It looks like
Sujit, you're not clear. Can't hear you.
We can't hear you, Sujit.
It's your screen is frozen too.
Is it?
Yeah, I think now fine.
Is it visible?
Yeah, it's visible. You can
Okay.
move the.
Yeah.
If you move the slide, we'll.
Okay, so you could see the clinical picture, right?
Yeah.
Yes.
Right? Okay, so this was the clinical picture when he presented to me with a very angry-looking eye with a total limbal stencil deficiency. I can hardly make out the details in the AC other than the eye will shine. A small area of lid margin keratinization, but not as what we see in Stevens-Johnson syndrome. There were no significant symblepharon. So actually, from the Apex Institute, I received the letter that they were suspecting OCP, and I was requested to do the necessary further management and the investigation and management. Since I saw the clinical picture, I started a short course of systemic steroids. He was also diabetic, so I'm very sorry, topical steroids, which did not show any clinical response. And in the meantime, I got the consent from them regarding conjunctival biopsy. Thanks, Dr. Anil. It was done at Amrita. The IF reported as having +1 fibrin linearly along the epithelial basement layer, and they called me up to say it could be a lichenoid etiology, something like lichen planus. So I got a dermatology consultation which showed no signs of lichen planus on the skin anywhere. And when I checked the reports, the isolated ocular lichen planus was reports are there, so it was suspected and it was put as a working diagnosis. As per the reports, I started him on local immunosuppression. Initially, it was tacrolimus, but then unfortunately he couldn't get tacrolimus, and I shifted to cyclosporin later. So the clinical picture slightly improved. The vision improved to almost 5/60 to 6/60 discorrected vision. Now you can see the pupil and all those details slightly. And patient was having a subjective improvement, and the plan was to continue treatment. When he presented with a very severe, this was not the actual picture, this was after cleaning the discharge. He was having very purulent discharge and with an acute conjunctivitis-like picture. So the culture was taken from the discharge, and it was showed Streptococcus species. And as per the sensitivity, he was managed with the antibiotics. And to avoid a lot of medicines and the medicamentosa, I actually stopped for a while the anti-glaucoma medicines and also the cyclosporin. But to my surprise, I saw that by the time his infection, conjunctival infection, got cleared, his cornea also got cleared, the angry-looking eye also got cleared, and now he's having a reasonably very good vision. Not very good, but 660, he's reading one letter in 636 as well. So, should I revisit the diagnosis? Because I came across a report that there could be something called a brimonidine-induced lichen planus, and he was on brimonidine or combination medicine of brimonidine with timolol for a long time, even before his cataract surgery for glaucoma. So, anyone who has encountered such a case, or what is the opinion of panel, and what is the diagnosis?
This case report, you must have read this case report. Have they done the histopathological analysis also? So did they, or was it a clinical diagnosis what they have reported, the brimonidine?
No, very, very coincidentally, actually, I got the full text only today. And just I brushed through that, and they are saying it is a biopsy report. As per the biopsy report, they have put it as a lichen planus.
Biopsy proven? No, okay, very
proven,
interesting.
yes, IF, immunofluorescent.
Okay, that's very nice. I don't think I've not come across anything like this.
Yeah, that's very interesting, Sujit. Yeah, interesting case, interesting piece of information, because normally we do attribute drug-induced pseudopemphigoid. You can to anti-glaucoma medications, but a case of lichen planus related to use of anti-glaucoma medications is something that I have also not heard of.
Sujit, was there a causality established there, or was it a chance occurring? Because if you look at the number of brimonidine usage across the world and the incidence of one case report, I think you must report your case also, because these are the cases which actually gives a lot of credibility in the literature, where we see more than one cases and we know that, okay, certain can happen. But one off case when we see, then we think about chance occurrence, or is there a causality which is established?
Surely, I hope I can report this case. I'll first go through the report, the full text and detail, because as you told, there could be some factors that may be confusing also in this. But from the clinical presentation, how is it different from the pseudopemphigoid? Is that symblepharon, or lack of symblepharon, a characteristic feature in this?
If there was no subconjunctival fibrosis or a band of symblepharon that you actually notice, because sometimes to actually see that, you have to stretch the lower lid significantly and ask the patient to look up or the other way around to see for presence of any of these changes. And if you feel that there were none of those, usually in drug-induced pseudopemphigoid, you can see those, mild changes, the subconjunctival fibrotic changes. So the difference between pseudopemphigoid and pemphigoid is that you don't have the autoimmune deposits in the basement membrane zone in pseudopemphigoid, unlike what you see in OCP. And with the withdrawal of the medication itself, the inflammations should subside. And when you do a biopsy, you don't really see the classical changes that you see in OCP. But again, you do have true OCP patients also, where sometimes the biopsy might be negative. So the usual way that we treat patients of pseudopemphigoid related to AGM is we try to shift over to systemic acetazolamide for a period of time to see whether that abates the inflammation in the surface. Use topical steroids if the glaucoma allows us to, just the soft steroids, and see if we are able to get the inflammation down. And if we are still not able to differentiate between the two and the patient requires an intraocular surgery, we do go ahead with the procedure under systemic steroid cover at least. even if we feel that it is the AGM to be blamed.
Okay, now I'm confused, like whether I should restart cyclosporin or stop brimonidine.
See, the thing is that I think if you have an alternate to the AGM, you can try a different class of anti-glaucoma medications. Yeah. Otherwise...
Yeah, go ahead, please. Sorry. Go ahead.
So, and use lubricants and see if it comes back, then you know that probably it is related to the use of the medication. Because that's the only way, like Himanshu said, if you have to prove cause and effect, you will know only if you use the medication and you have a recurrence of symptoms, you will probably know that it's related to the medication or not. But at this point in time, if you're suspecting the medication to be the factor, then probably stop that and see whether you have an alternate to it.
Yeah, now there are those preservative-free anti-glaucoma medications that are available in Indian market also. So I guess they surely can try, and that's what normally we advise them to do, that just to see the effect, like what we are getting, because stopping the anti-glaucoma medication may not be acceptable by the glaucoma consultants. And also staining pattern, like I wanted to know about the staining pattern when you had that acute congestion, what you showed. It would be interesting to show the staining pictures related to your case.
I have staining picture. I have stained it, but I don't remember to have any particular pattern, and I couldn't find it in my, recorded or documented thing. No ulcer. No.
Yeah.
No raw areas were there. Yeah.
Very nice. Very nice. You must write.
I hope so. Dr. Kaup, any comments on it?
Oops, wrong one. So I think that I have seen one patient that is similar to that. And I guess the other thing, you can check with the lichen plainness is the plasminogen factors. Did you look at that too?
No, I haven't.
Other factors. I think it probably is medication induced, but there is the other, potential cause of a lichen plainness appearance. So I would say, as Dr. Geeta says, keep off the medication and see then how the patient does, because it certainly was a remarkable improvement, and then see if it comes back.
Okay, thank you. I thank Dr. Arjun. I think he is in the viewer's box. So thank you for referring this case to me. Now I think we can have a small poll. The technical team can post the poll, and we don't have any academic talks after this, and we will wind up after this poll. Okay, they have informed me that I can do my vote of thanks, then the poll will come. So as we are coming to the conclusion of this part 1 of our program, Unlocking Ocular Surface, on behalf of Kozhikode Ophthalmic Society, the Kerala Society of Ophthalmic Surgeons, and all the viewers, I convey my sincere gratitude and thanks to all the speakers and panelists for such a wonderful presentation. We have got a lot of messages in the chat box. Messages were regarding your super presentations rather than questions. So first of all, let me thank Dr. Karl Karp. Dr. Karp is always busy, and I know, and now, even now, because of a post-lockdown surge, she's having a lot of ocular surface tumors patients rushing in for her. And finding a date, a topic, scheduling time, everything was challenging, but she cooperated very well. My sincere thanks to you, madam, and for virtually visiting Kerala, which is otherwise known as God's own country. I hope you know, and sharing your knowledge and your expertise to us. Thank you very much. Next, Dr. Geeta, I know you're always willing and enthusiastic for your ocular surface talks, but now you are less occupied because of the severe lockdown in Chennai. And I know you are busy playing the role of a good homemaker now. Thank you very much for sharing your time, precious time with us. Sorry for squeezing out so much from the two large topics. Thank you very much. Dr. Himanshu will remain one of the most sought out speaker for you. You will Kerala is your second home. Thank you for joining us in very short notice and for all the wonderful dry eye tips, with one tip extra for us, and also for chairing the session. Thank you, Dr. Anil and Dr. Vinay, for moderating the session so well. And thank you. I must thank Dr. Meena Chakrabarti, Dr. Mahesh, and Dr. Rajiv from KSOS, Office Bearers of KSOS, for their presence and blessings. And dear friends, after 7 days, on 26th of July, we have part 2 of this program coming up with Dr. M.S. Kerr from Bascom Palmer Eye Institute. He was there in the viewers box today for some time. Then we have Dr. Namrata from All India Institute and Dr. Vikas Mittal. All of them are, again, star-studded faculty. So request all of you to come back and join us in the next meeting also. Sincere thanks to all the viewers. We had a few fellows, PGs and viewers outside the boundary of our small state. So thank you all for joining. Thank you, Omnicurious, for such a good platform and background work. Thank you all. I think the poll is happening in the background, or it's going to happen. Okay, I think a poll was happening in the background. I couldn't see, at least.
It shows beyond expectation 31%, excellent 56%, good 12%. So everybody liked.
So can you see Dr. Karp? Yeah, so happy.
I'm sorry, I couldn't hear you.
Yeah, it's a poll. There's a poll happening in the background, and it says that the session was beyond expectation 31%, excellent 56%, good 12%. So
excellent.
Most of the people have enjoyed it. Thank you very much. Thank you all the panelists. Thank you once again.
Thank you, Sujit.
Thank you.
Bye-bye.
Thanks. Thank you.